Dr. Ajayi? Dr. Ajayi?
Yes.
I think you might have to disable people from commenting. Are you going to do that when we start? Or?
No, they can't talk. They can only write.
Okay. And it's not
only those of us who are panelists who can talk.
Okay.
Yeah. All right. So I guess we're good to start. It's 1 o'clock from my watch. Great. So thank you so much for joining us. You're welcome to the second day of the International Conference of African Endometriosis Awareness and Support Group, which is held in collaboration with the Society of Gynaecologists of Nigeria, and which is tagged to recent advancements in endometriosis diagnosis and management. The one was highly successful. We had over 800 participants from 21 countries, and we look forward to another successful webinar today. On the panel, as usual, is the president of SOGON, Professor Rotimi Akinola, who has given us tremendous support to make this possible. It's also my pleasure to introduce Professor Akin Odukogbe of the University College Hospital Ibadan to join us as a moderator. As usual, we have a group of seasoned speakers to make this webinar memorable. I'm going to hand over to Professor Akinola, and after him, Professor Odukogbe, so that they can say one or two things before we get the ball rolling. So, my president, I bow and tremble.
I think he's just left. Network problem, I think.
Yeah. Okay. Akin.
Yes.
Okay. Do you want to say anything before we introduce the speakers? Because we want to get things rolling. Do you want to probably introduce yourself or say anything before we get the speakers going?
Thank you very much, Dr. Yomi Ajayi. I'm Professor Akintunde Odukogbe of the University College Hospital, Ibadan. And I'm happy to be here as a moderator for this very important topic, one that is causing a lot of burden for reproductive age group women, not only in developed countries, but as we are seeing now, causing same challenges in developing countries. And this afternoon, we have a seasoned panel of speakers who will tell us, will ask questions. There are two of them, their topic, two or three of them, their topics are questions. They're going to answer them. And others will tell us about impact and management of this very important disease. So I welcome everyone on board. Thank you.
Yeah, President, you have the podium.
Thank you very much. You're all welcome to the second session of our endometriosis. Last week, we were talking about the diagnosis and we talked about butchers who will probably make something of whatever is left. So we have a seasoned panel of experts who are going to talk to us about the after effects or whatever it is that endometriosis causes and how to live with it, how to make do with it. We're talking about fertility here now, we're talking about symptoms relief and everything. So it is my pleasure actually to welcome you all to this particular session. And we will be introducing the experts as they come, as they go along as we are taking their sessions. Dr. Abayomi Ajayi, like I said last week, it's because of his tenacity that we were able to actually establish the African group. And it's been long coming since the endometriosis support group that he launched in Nigeria. The Society of Gynaecology and Obstetrics of Nigeria is very, very proud and very, very happy to be associated with this. And then because he wears two caps, he's also the chairman of the Continuing Medical Education group of the Society of Gynecology and Obstetrics of Nigeria. So it's natural that we push along this frontier, and endometriosis was something that a lot of us believed was probably immune from it, or that the prevalence was low in Africans. But from evidence and from everything we see that we had been wrong. It's been there all along. It's also there even in our youth at the age we didn't even think it was. So that's why we are spreading this awareness and making everybody know, and then also to go into the clinical compartment to see what it is that it causes and how we're going to be able to ameliorate this. So I welcome you again to the symposium, let's call it that. Dr. Ajayi, please kindly take on, introduce the first speaker for us so that we will then go on from there.
Thank you so much, Mr. President. The first speaker is a very good friend of mine, Professor Francisco Carmona. Professor Carmona has been a professor at the University of Barcelona, Department of Obstetrics and Gynaecology since 2006. His main areas of interest are endometriosis and benign diseases, including pelvic floor pathology. He has organized advanced endoscopic courses and workshops on minimally invasive surgery from 1990. He has published over 100 scientific articles and authored more than 20 book chapters. Dr. Carmona is member of the editorial board of Gynecological Surgery, Journal of Endometriosis and Pelvic Pain Disorders, and Medicina Clinica, as well as is a member of ESG, EAGL, and so on and so forth. Professor Carmona is not going to be here today. He has recorded his lecture, but he's going to try to join us because he's not presently in Barcelona now. Where he is, the network is not very great, but he's going to try to join us to answer questions. So we're going to play his recorded. If I did not warn you, you might not know that it's recorded. So it's very, very well done. So we're going to listen to Professor Carmona now. So Professor Carmona has the podium now. Thank you so much.
Here, okay, everything is working now. My name is Francisco Paco Carmona for the friends. As Dr. John Yamagi is, I want to thank him for inviting me to share with you this time. I am from Barcelona in Spain. I work in the hospital clinic, probably the most important hospital for sure in the city and probably in the whole country, in Barcelona. This hospital is located just in the middle of the city. Is approximately in the geographic center of the city, a city that if you have never been here, I strongly recommend you to visit the city. You will find a lot of wonders, of different wonders, of amazing buildings, very nice sea, very good food. And I want to point out that some of these wonders has been shared with your country, shared with Nigeria. Maybe some of you may still remember Amunike. Okay, maybe Amunike was not so wondrous. He used to be when he was playing with the Nigeria team. In Barcelona, maybe he was not so good, but for sure, I think it's important to remember him now. As I told you, it's my pleasure to start my presentation today. Just asking about, just talking with you about the evidence that we have to state that there is an association between endometriosis and infertility. I want to thank again Dr. Abayi and the African Endometriosis Awareness and Support Group for inviting me today. My objective today is just to analyze if there is a cause-effect relationship between endometriosis and infertility. All of you know that we are always speaking about infertility and endometriosis, but I want to be sure, I want to analyze with you if this association is a cause effect or is simply a causal relationship. You know that endometriosis is a estrogen-dependent inflammatory disease in which it's a chronic disease in which endometrium-like tissue, including both the stomach and glands, is present and grows outside of the uterine cavity, mainly in the peritoneum and the ovaries. There are different forms of the disease, as a lot of years ago was described by Donev and Dison, the superficial form of the disease affecting the peritoneum, the ovarian endometriomas, the cysts in the ovarian, and probably the most severe form of the disease, the deep endometriosis. And we have not to forget about the existence of adenomyosis. Adenomyosis for some investigators, it is a special form, a different form of endometriosis, and for other investigators, adenomyosis is a different disease, closely related with endometriosis, but a totally different disease. We know that the main symptoms, sure, the symptoms of endometriosis are a lot and different, but the two most important symptoms in endometriosis are pain, form of dysmenorrhea, dyspareunia, chronic pain, and infertility. Most of the patients complain of pain, and only 50% of the patients complain of infertility. Vice versa, the prevalence of endometriosis in patients with infertility is around 50%. And all of you know it is very well known, and for sure all of you know that the fecundity, the monthly fecundity of patients with endometriosis is lower than the healthy patients. In healthy patients, it's to be around 15–20%. That's the monthly fecundity rate, and in patients with endometriosis, this rate decrease very importantly, being around between 2 and 10% as maximum. But this association that for sure it exists, is such association is a causal one, or is maybe an spurious relationship, is maybe just a coincidence, or what kind of relationship exists between endometriosis and infertility? It is my main goal today is to discuss with you this topic. For considering that our relationship is a cause-effect relationship, we have guidelines from the criteria from the evidence-based medicine supporting which kind of relationship we have between two variables. We need to know the type of association between endometriosis and infertility between the two variables. We need to know if there is a temporal relationship between the two variables. In this case, between endometriosis and infertility, is endometriosis before infertility, or maybe infertility already exists before that the patient starts with her disease, with endometriosis. Is there a dose response variance? I mean, is there a more important effect on infertility, a more severe infertility, as more severe is endometriosis? We need to analyze this precaution. And does this association make sense? I will translate. Is there a biological possibility of this association? Is biologically possible that endometriosis and infertility are related or not? And finally, which is the effect of removal of the excision of the endometriotic lesions on infertility? The infertility may improve after we remove the lesions, it is another question that we need to answer before considering that the relationship between endometriosis and infertility is a causal one. Look at the data. Look at the literature and try to answer those questions. Obviously, we need to, first of all, we need to analyze which kind of association we have between endometriosis and infertility. For sure, we don't have any evidence coming from experiments in human beings, because there are ethical considerations that preclude to perform well-designed experiments in women, and most of the evidence came from the experiments in animals, mainly the baboons. The baboons are, superior primates that they present spontaneous endometriosis, and they are a very good model for inducing endometriosis in order to study the disease. The anatomy of the baboons, the physiology of the baboons are very similar to that of the women, and we have now evidence coming mainly from the baboons, as I told you, but also from other animals, but mainly from the baboons. We have evidence that support the concept that the different changes that we see in the patient with endometriosis and infertility, is possible to observe those changes in the experimental model, like inflammation, like systemic neurological changes, and another changes that we can see in infertile patient with endometriosis. Furthermore, we have seen that fertile baboons in which we induce endometriosis, they become infertile. We have seen that as more severe is the endometriosis in the baboon, much lower is the fecundity rate in that animal. So we have very, very strong evidence coming from the experimental model showing that there is a probably causal relationship between endometriosis and infertility. We need to know also what is the strength of the association. Unfortunately, the only experiment that we have are experiments in retrospective studies. There are not prospective studies. It is very difficult to have prospective studies analyzing this point, because we need two groups of women. We need women that are very similar, controlling the two groups regarding age, feminine, coital activity, social class, the male factor, and we need to perform a laparoscopy, or at least a very complete imaging study, just to be sure that there are no endometriosis in patients that, remember, they are not infertile. We need just to study the patients and look for fertility. So by integration, we will never have this kind of studies. But we have also some evidence from coming from observing the studies that showing exactly the fertility, the fecundity rate, the fertility in patients with and without endometriosis are different. In this slide, you can see how the time of conception between healthy patients and patients with only mild endometriosis, not severe endometriosis, only mild, only moderate forms of endometriosis, are much much lower in patients with unexplained infertility. In a very similar way, other people study the chances of spontaneous pregnancy while the patient is in IVF waiting list, and you can see here if tumor pathology has a hazard ratio is 1 because it is the reference group. The endometriosis has the lower hazard ratio comparing with all the other factors for spreading the infertility in those patients. So there are evidence suggesting that effectively the problem is the endometriosis. Again, to compare groups, the different groups and outcomes, we need prospective studies, as I told you some minutes ago. This is not possible to have because the ethical reasons. Maybe we can use as a control group patients, fertile patients that are performing a tubal sterilization, but it is very difficult to control the groups for all the different variables that may influence in this sense. For sure, we need to also to take into account the possibility of having an adenomyosis, associated adenomyosis that may explain also some groups of infertility. Again, our system of classification is not perfect. It is a summary of the slide showing you the main classification system, that is the classification of the American Fertility Society, that you know is not a perfect one. So we need to wait for having more and more form of a new classification. We are working with Professor Abrao in trying to have a new classification, and probably in the next weeks, maybe some months, we will be able to present you a new classification that fortunately will have a more strong correlation with the different symptoms, including fertility, presented by the patient. Another point to assess is the consistency of association between endometriosis and non-endometriosis. First of all, the prevalence of infertility is increased in patients with endometriosis, and again, the prevalence of infertility is increased in patients with endometriosis. Around 25 to 50% of the patients, infertile patients, have endometriosis, and vice versa, 50 to 50% of women with endometriosis are also infertile. We have also more evidence of this consistency of association between endometriosis and non-endometriosis. For example, the effect on spontaneous conception, the effect on reproductive outcome of intrauterine insemination, on the effect of the reproductive outcome, the effect of endometriosis on the reproductive outcome of ART procedure. You can see here some examples. I have already shown you this slide. It is the spontaneous fertility rate of patients with endometriosis and without endometriosis. Or again, this slide that I showed you some minutes ago. Yes, the time to conception in the patients with infertile, with unexplained infertility and with mild endometriosis. And look at those slides. Yes. So this is a new slide. The intrauterine insemination rates, pregnancy rates in patients with unexplained infertility around 33%, and patients with minimal endometriosis around 16%. This new slide is some way old slide. This as I came from the 2015, in which patients with more mild forms of endometriosis has no difference, although there is a tendency to have lower pregnancy rate, but patients with severe forms of endometriosis, using the American Fertility Association classification, has a lower pregnancy rate in IVF procedures. But very recently, this paper coming from the Society for Assisted Reproductive Technologies database clearly shows that all the patients with endometriosis, independently of the severity of the disease, has lower oocyte yield, have lower implantation rates, and have lower pregnancy rates after IVF. Then we need to assess if there is a temporal relationship between endometriosis and infertility, which is the first. Is the first endometriosis, the first is the infertility. Well, also the dose response gradient should be evaluated. Is the infertility more frequent in patients with severe forms of endometriosis, or is the infertility more frequent in patients with another form of endometriosis? This paper is a relatively recent paper, 4 years ago. It was based on the study of the health nurses study, and clearly showed that patients with endometriosis, with previously known endometriosis, are more prone to develop infertility than patients, are healthy patients. And again, our classification system is not so good, and then we are not able to clearly show that as more severe is the endometriosis, more frequent is infertility. But for sure, there are some evidence suggesting this point. But we need, again, this is very important that we work in a new classification, with more clear relationship with endometriosis, with the outcome of the endometriosis, the prognosis, the outcome, etc. Maybe the endometriosis fertility index is a very important classification, and that has been clearly shown because there is a lot of evidence suggesting that as more severe is the endometriosis after the surgery, the less is the chance of the patient to conceive. 4th point. Is there a biological possibility of the association between endometriosis and fertility? And again, the answer is yes. There is a clear biological explanation about how the endometriosis may provoke infertility in our patients. There are a lot of different mechanisms, that has been shown in endometriosis, maybe from the hypophysis and hypothalamus, with the alteration in the pituitary and ovarian axis, with alterations in the source of luteinizing hormone. There are problems in the ovulation and the ovary. There are failure oocytes. There is altered oocyte quality in patients with endometriomas. There are an impaired folliculogenesis. There are failure follicles, maybe because the endometrioma itself, or because the surgery of the endometrioma. There are an alteration in the steroidogenesis, but also there are the inflammatory ambience that there is in the pelvic cavity may reduce the fertilization rate, maybe affecting the oocyte, or maybe affecting the sperm by affecting the quality of the sperm, or maybe affecting provoking a poor sperm building. And also there can be effect on endometriosis, on the inflammatory effects, on the immunological, the oxidation that there is in the endometriosis may affect the pre-implanted embryo by impairing its quality and by provoking an early embryo development arrest. And also there can be, that the normal endometrium is affected by endometriosis. There are altered hormone regulation. That there is a progesterone resistance that may impair the implantation rate and also affecting the uterine receptivity. But don't forget that also the pregnancy itself can be complicated by endometriosis. And then there will be a reduced live birth rate. And yeah, for my last point is to analyze the effect of the removal of the decisions of the endometriotic lesions, and it may improve the infertility in our patients. Again, the answer is yes. There is a very classical study from the Cochrane database that remember the Canadian study and the Italian groups that clearly showed that the laparoscopic treatment versus the diagnostic laparoscopy improves the live birth rates and the ongoing pregnancy rates. More recently, this study was published some years ago in the European Journal of Fertility and Gynaecology, showing that the rate of both spontaneous pregnancies and IVF pregnancies are increased in patients, in infertile patients, after the excision of the lesions. And this is a very nice paper published by my good friend David Soriano from Israel, showing that patients with more than two or more previous IVF failures and with deep endometriosis, and that they were submitted again for IVF after performing an excision of the deep lesions, you can see here, 40% delivered. Some of them after the spontaneous pregnancy, and some of them after a new cycle, a new IVF cycle. And let me show you those data. Those data are very, very, very new data that we have submitted now for publication. And you can see this is a meta-analysis. We have performed a meta-analysis just trying to analyze the patients who have an indication for IVF, patients with deep endometriosis and with an IVF indication, which is the result of the IVF if we perform the IVF just after the diagnosis or just after the surgery, and without giving the patients the possibility of look for a spontaneous pregnancy. And look, there is the pregnancy rate per patient that is clearly positively associated, significantly associated with a more higher pregnancy rate per patient after if we perform the surgery after the IVF, if we perform the IVF, after the surgery. The same exactly if we look at the pregnancy rate per cycle. The same exactly if we look at the live rate per patient, or the live birth rate per cycle. In all the cases, if you perform the IVF after the excision of the deep lesions, we will have a better result in those cases. So just to conclude, using the techniques of evidence-based medicine, we found that there is a causality relationship, a causal link between endometriosis and infertility. Because there are the strong association in prevalence, in the natural conception rates, and also in the ART rates into the insemination IVF. There is a temporal relationship between endometriosis and infertility. There are a tendency to have a more frequent infertility in cases of more severe endometriosis. And finally, there is a proven beneficial effect of removing the endometriotic lesions. Thank you very much for your attention, and let me to invite you to the 6th Congress of the SOGON. This 6th Congress was cancelled in May because of the pandemic, and now the next month we will perform it in a virtual manner, and I want to invite you to this SOGON online week that we will perform the first week in November. Thank you very much for your attention. And thank you again, Jamie, for inviting me.
Thank you very much. Brilliant lecture. Every time you listen to Dr. Carmona talk about this, you are excited. That's brilliant. We will leave all questions. If you have any questions, please just type them in the question and answer period so that we'll take them at the end of the session. Professor Carmona, thank you again. We will now go on to the convener. That's chairman of our continuing medical education series in Society of Gynaecology and Obstetrics of Nigeria, a man of no mean repute himself, Dr. Abayomi Ajayi. I said he's tenacious. I said he has pushed anything he pushes such that like some of us call him bulldozer as far as that's concerned. He'll be talking to us basically about endometriosis and infertility and raising that question, who needs it? Don't forget that Carmona had been talking about, is there evidence base that infertility, that endometriosis actually causes infertility? And I'm sure he's done a lot of justice to that. So Dr. Ajayi, so who needs it? Who needs assisted reproduction? Thank you very much. I invite you, Dr. Abayomi Ajayi, to the podium.
Thank you so much, Mr. President. It's so great to be here today, to be on the other side of the podium speaking. My name is Abayomi Ajayi. I have nothing to disclose, no unusual thing to disclose today on this topic. I'm talking about who needs ART when you have endometriosis and infertility going together. Well, Professor Carmona has given us this background on the relationship between, or the association between endometriosis and infertility. He's spoken about this slide where Edward Hughes of McMaster University actually gave us this, was the one who talked about the quantitative overview of control trials in endometriosis associated infertility, which he published in 1993, which showed that there is a reduction in natural fecundity in women who have endometriosis. Well, just like Professor Carmona said too, about 30 to 50 to 40% of women with endometriosis will have infertility. And this was also published by Ruiz in the original paper titled Clinical and Laparoscopic Characteristics, Incidence of Endometriosis in Infertile Women. It was actually in Spanish. And recently, Gyasi from Michigan State University, also in his paper, is endometriosis more common and more severe than it was 30 years ago, showed us that this same thing is still, the incidence is still the same. And Professor Carmona told us about the possibilities, the mechanisms possible, pelvic inflammation. I think one thing we need to understand is that endometriosis is a disease of inflammation. So inflammation is everywhere in the peritoneal cavity, in the uterine cavity. And so you can have all this tuber damage can happen from the fact that the woman is bleeding into her abdomen. We have seen also that there is reduced ovarian reserve, which may be related to the endometrioma. This is one very interesting thing that the group in Belgium showed that whether you even operate on endometrioma or not, that they tends to reduce ovarian reserve in what they describe as the burnout process. That the normal ovarian tissue that is near to any endometrioma generally just does not do very well. There is reduced ovarian reserve in them. And then we know about these people, just like Carmona said also, they have a lot of dyspareunia and sexual dysfunction. And so naturally they don't have enough sexual exposure. And then there is associated adenomyosis, which Professor Ziang is going to be talking about later on. Adenomyosis is a nightmare to us as reproductive physicians. And recently also there was a lot of publication about this altered oocyte quality in endometriosis. And it was started first by the publication by Sanchez in 2017. And then February this year, there was a lot of publication about infertility preservation, which Dr. Larogun will be talking about later on today, showing that the oocytes of women who have endometriosis have lower quality than those of people who do not have endometriosis. Well, to the management, there is no doubt that ART represents the most efficient and successful management of endometriosis-related infertility. This was said by Eric Sori in 2015. If you follow me in the next few minutes, I'm going to attempt to address three main questions. Who needs ART? When do you do ART? And how do you do ART? I think the first thing I need to establish is that when we have a patient who has endometriosis-associated infertility, we need to do the comprehensive fertility assessment, okay? And this, we're talking about the semen parameters. We all know all that, ovarian reserve. We need to do the tuber status. And there's one thing again in this environment that we need to do the uterine cavity assessment. This from the fact that we did a study, we reviewed about 900 patients with infertility. We saw that 61% of these patients have intrauterine abnormalities. And half of these patients, that's 30% of them, were intrauterine addition. So this is a common thing in this environment. And when you're thinking of anybody, I'm not talking about you must do hysteroscopy, but a sono hysterography or water scan will suffice as a screening method to look at the uterine cavity. Now, there's so much controversy in the treatment of women who have infertility and endometriosis, but one thing that everybody agrees on is this, that drugs or there's no place for hormonal treatment when you're talking about infertility with endometriosis. And the ESHRI guideline also clearly states that. So that's one place that we all agree. Usually, you know, when the last week and then this week when we were talking about butchers and wizards, and that's what we try to categorize people who treat endometriosis-related infertility. Some people are lucky to be the two. Some people are just one. So there's some people who are just so eager to do surgery, and some people who just want to do ART. There needs to be a handshake between these two, and that's the handshake is what we're trying to be able to establish. And there's a lot of pushback from the two groups, but I think we will try to establish a meeting point, especially taking the patient into cognizance. One of the things that we need to continue to do is we need to continue to talk to the patient look at the patient. We are treating patients, we are not treating endometriosis. So I'd like to start with the ESHI guidelines published in 2013 on the management of women with endometriosis. And it says that in infertile women with stages 1 and 2 endometriosis, clinicians should perform operative laparoscopy, excision or ablation of the endometriotic lesion. We saw it from Carmona's presentation of excision over ablation. So including adisolasis, rather than performing diagnostic laparoscopy only to increase ongoing pregnancy rates. In other words, there is no place for you to do diagnostic laparoscopy when there is infertility-related endometriosis. And the second recommendation is about the advanced stage. It says in infertile women with stages 3 and 4 endometriosis, clinicians can consider operative laparoscopy instead of expectant management to increase spontaneous pregnancy rate. So we can see the difference in the language. With the early stage endometriosis is more assertive, with the late stage endometriosis is more doubtful. But one thing has also been seen when you do surgery for endometriosis, that the pregnancy, time to pregnancy after surgery is usually, the peak period is 12 to 15 months. In other words, where there is no point in waiting for more than 12 months, but we'll see there's some other things that we need to consider if you're even thinking about surgery. Because the present thinking now is to resort to as quickly as possible to ART, except in these conditions, when you are persistent uncontrolled pain, or you are seeing that you have endometrioma and there is rapid growth of endometrioma, or there are suspicious features of an ultrasound of your endometrioma, or there is a potential rupture, there is a chance of potential rupture in pregnancy, or you think that you will not be able to access your follicles when you are going to do your ART, then you will be thinking of surgery. The people are trying to push surgery a little bit to the back because we have seen that after surgery, there is a lot, the AMH reduces. Actually, there was an RCT that shows that if you do only one side, one ovarian endometrioma, you could reduce the AMH to about 40%. If you are doing the two sides, it could be reduced to as much as 60%. So when you have a patient who has infertility and endometriosis, your decision to do IVF is easier in the presence of the following. When the tubes are compromised, that's why it's important for you to do a comprehensive fertility assessment. When you have blocked tubes, then there's no point in waiting. When there is the presence of a male factor, the male factor is already compromised. There is no point in waiting at all. If the woman is over 38 years, then you must know that you must be giving her ART immediately. And when we talk about ART in endometriosis, the role of IUI is very limited because we know that the pregnancy rate from IUI is reduced to about 50% in the presence of endometriosis. Now, that's my next point. If you have tried IUI and it has failed, other treatment methods have failed, then you don't have a choice but to resort to IVF. And then when you have advanced stages 3 and 4 diseases, you might have to do IVF. Now, we're talking about IVF being the main treatment for endometriosis-related infertility. But what are the figures saying? What is the experience? There's still a lot of controversy from what you heard from Professor Carmona about the effect of endometriosis on IVF outcome. He also looked at the paper by Barnhart, which was published from the University of Pennsylvania. Barnhart did a meta-analysis involving 22 published studies, which showed that you have reduced suicide retrieval from patients with endometriosis, there was reduced fertilization rate, there was reduced implantation rate, and of course, reduced pregnancy, reduced chance of pregnancy. And the more recent paper from the same University of Pennsylvania was written by Sunita Senapati, who used SAT data, just like Professor Carmona showed us. And the data involved 347,000 cycles, both fresh and frozen, from 2008 to 2010 in a retrospective cohort study. And she also showed that there was reduced oocyte yield. There was especially pregnancy rate was really lower, especially once there is also another concomitant disorder. For example, like if you have a reduced sperm count. No, but let's look at what is the experience, all this, the experience that we have with endometriosis and IVF. And we can summarize it as such. When you have a patient with endometriosis, the dosage of gonadotrophins that you are going to need and the duration of stimulation is likely to be more increased. Just like we read from the other papers, reduce oocyte number and possible quality. The cycle cancellation rate is higher. And this is one very important thing. Actually, in our own review, we looked at about 300 patients with endometriosis. And what we saw was that cancellation rate, cycle cancellation rate was about 12% in patients who have endometriosis. Well, there's a paper that I'm going to show you which shows that ICSI may also give better results in terms of the fertilization rate and the number of embryos that you end up with than conventional IVF. And then we see that there's reduced fertilization rate, there's a reduced implantation rate, and there's no doubt that pregnancy outcome is poorer in advanced diseases, especially patients with significant ovarian involvement, what we call endometriomas, or patients who have had prior ovarian surgery. Well, there's also always this discussion about, is it the oocyte that is the problem or is it the endometrium? I'm not going to get into that debate today because it's a lot of things that are involved. But I would like to say that the two are involved. That's why I say it's the story of the chicken or the egg. You have to choose which one you think it is. But what I think is important for us is to see how can we get the maximum benefit from IVF. If we already know that IVF is probably the most efficient method to treat endometriosis-related infertility. How can we get maximum benefit from it? Well, there's always been this argument that has been on forever, which also Professor Carmona alluded to, of doing surgery before IVF. Yes, if there is pain, I agree, but if not, some people also believe that as much as possible, if you can avoid surgery, because I've told you some of the things that surgery might be able to do as regards AMH after that, and ovarian reserve. And there is a recent paper published in Journal of Minimum Invasive Gynaecology, February this year, from Australia by Matthew Lunardi, which when he asked the question when to do surgery and when not to do surgery for endometriosis, which was a systemic review and meta-analysis. And he concluded that operative laparoscopy may improve overall pain levels, but may have little or no difference with respect to fertility-related or adverse outcomes when compared with diagnostic laparoscopy. So if you probably don't need to, if you don't need to do surgery, then don't need to do it. One of the other papers that shows that the fact that you see endometrioma does not mean that the patient will have infertility. So, because sometimes there was a time that once we saw endometrioma, everybody was chasing after it, even when the patient was not even complaining of infertility. So I don't think that should be done. Now, the other thing that I want to talk about is prolonged downregulation. I think this started from 2006 when Salam and Velasco published this paper on long-term pituitary downregulation before in vitro fertilization for women with endometriosis. And it was supposed to be the tiebreaker then. It was a Cochrane study. Only 3 randomized studies were included with 165 women. And their conclusion was that the administration of GnRH agonists for 3 to 6 months prior to IVF in women who are undergoing IVF or ICSI with endometriosis, that the odds of clinical pregnancy is increased by 4-fold. Yeah, that was then. That was, everybody embraced it then, and we were doing a lot of things. But a recent meta-analysis was also done, and again by Cochrane. This one was like a collaborative study, doctors from the UK, from the US. Salam also was involved with this. And now they looked at, there were 8 randomized studies, randomized control studies, involving 640 patients. And what they saw was that the quality of the evidence was very, very low. And what they looked at was live birth rate, overall complication rate, clinical pregnancy rate, multiple pregnancy rate, and miscarriage rate, and the mean number of oocytes. This was by Jojo. It was in November 2019. And the conclusion from the authors was that they did not find any, I'll read straight from their finding. Contrary to previous findings, we are uncertain as to whether long-term GnRH agonist therapy impacts on the live birth rate, or indeed the complication rate compared to standard IVF ICSI. Further, we are uncertain whether this intervention impacts on the clinical pregnancy rate, multiple pregnancy rate, miscarriage rate, mean number of oocytes, and mean number of embryos. In the light of paucity of and very low quality of existing data, particularly for the primary. Anyway, what they concluded was that they were not as sure at what we believed. And this, for people who also have some experience in treating endometriosis, I'm sure you must have been asking yourself the same question. Now, the other thing is the protocol to use. Is it the agonist or the antagonist? Well, what the paper, all the evidence is saying is that you can use them. But I am more comfortable with the antagonist protocol because it offers you the advantage of being able to trigger with the agonist. And that also, there was a paper published from Paris which showed that even pain that patients experience after stimulation is reduced when you are using an antagonist protocol and you are triggering with an agonist protocol, with a GnRH agonist. So this is what some of the people try to do, because you really don't want to have an ovarian hyperstimulation. We know that when you use antagonists with GnRH agonist trigger, your chances of having OHSS is very, very reduced. And that is one thing we also need. We owe the patients who are doing IVF, who have infertility and endometriosis. You don't want them to hyperstimulate as much as possible. I spoke about the ICSI and IVF debate. Yes, this was a study that was done from Israel by Elbaz, which used sibling oocytes from couples with endometriosis and homospermic semen. Sibling oocytes means oocytes from the same source. So they divided one part for IVF, another part for ICSI, and they saw better results with ICSI. So that's why we say it's likely that ICSI will give you better results when you have a patient who has endometriosis and infertility together. And this is also a recent study from Paris, which is showing that deferred frozen embryo transfer will give you better results than if you do fresh for patients who have endometriosis-related infertility. And this study from Bodon shows that the cumulative pregnancy rate when you're doing fresh from the fresh group was 29.6, whilst for the frozen embryo transfer was 43%, and then ongoing pregnancy rate was 17.8 for the fresh group and 34.8 for the frozen embryo transfer group. So that shows us that there is something that we might gain, and it stands to reason if we're talking about inflammation. And one other thing which is gaining so much ground with endometriosis and infertility now is fertility preservation, especially when you're doing surgery for young women. It's probably an opportunity for us to help them to preserve fertility, especially maybe if you have to open up into the patient, especially for patients who are having recurrent surgery. You know, who have had a previous surgery, they're having recurrent surgery, because we know that the more you enter into the abdomen for any reason, with patients with endometriosis, the more you're likely to reduce their potential, their fertility potential, because of, especially when they have endometriomas, because we know that the origin of endometriomas, no surgeon can say that I'm so careful and I can spare the normal ovarian tissue, because it's not a cyst, as it were. It's an invagination of the epithelium of the ovary. And then for, of course, people who have bilateral endometriomas, it's recommended is that they have fertility preservation done. And for people who have no immediate pregnancy desire, it's better that we try to preserve their fertility. I don't want to talk so much about fertility preservation, since Dr. Larogun is going to be talking about that later on. So I'm going to conclude by saying that when we talk about endometriosis and infertility, it's important to individualize treatment based on symptoms. Just like Dr. Carboni said last week, we don't treat lesions, we treat patients, we treat symptoms. So, well, if the patient has infertility, then he has to be treated. If the patient has pain, please, we might have to do that. And that's one of the things that we've spoken about, that pain is something we cannot ignore, even when there's infertility. And IVF can be used in all stages of endometriosis, preferably as first option, and 6 to 12 months after surgery. Repeated surgery should be avoided as much as possible. Counseling is very important, as cycle cancellation is more common, and multiple cycles may be needed because the majority of them might produce fewer follicles, fewer oocytes than the other patients. So you might need to repeat, do multiple cycles for some of them. And like we said earlier on, you might have to start with increased gonadotrophin dosage for their stimulation. It's better to avoid endometriomas at doing ovum pickup to reduce risk of pelvic infection. And then I'd like to end by saying that more studies definitely will be needed on deferred embryo transfer and fertility preservation, as it seems to be the diamond in the dust in the management of patients who have infertility and endometriosis. Thank you so much for listening.
Thank you very much, Dr. Ajayi. Like I said, brilliant as ever. And thank you very much for bringing all these things forth. Dr. Ajayi has emphasized particularly the fact that individualization of treatment in patients with endometriosis is key, and that endometriosis should be treated as a complex rather than as just lesions. So it's a patient that we are treating, and our counseling should be as such. He's talked about justification for ART in endometrioma. He has compared all the different protocols, regimen, and what's conventional versus ICSI. He's told us about fertility preservation, and it's been brilliantly done and simply elucidated. I'm going to call on the pastor in the house, that's the Professor Odukogbe, who is going to introduce the next speaker and call them to the podium. Thank you very much. Pastor?
Thank you very much, Mr. President. Can you hear me? Hello? Hello?
We can hear you.
Can you
We
hear
can
me?
hear you.
Okay, thank you. The next speaker is Dr. Olari.
Pastor, please move closer to your microphone so people are not hearing you well.
Okay, the next speaker. Can you hear now?
Very, very well.
Okay, the next speaker is Dr. Olarik Musibong. He's the chairman of the subcommittee on continued professional development at the Royal Thai College of Obstetricians and Gynecologists. He is in addition a member of the Thai Menopause Society, Thai Society of Reproductive Medicine, Thai Society of Gynecologic Endoscopists, the American Society for Reproductive Medicine, European Society of Human Reproduction and Embryology, and the American Association of Gynecologic Laparoscopics, in addition to the Society of Endometriosis and Uterine Disorders. He's going to talk on management of endometriomas, to remove or not to remove, which is coming at the heels of Dr. Ajayi's query about whether removing endometrioma is necessary. So I welcome Dr. Olarik. Thank you.
Thank you, Mr. Chairman, and thank you for the chairman. Okay. Okay, I would like to share my slide.
Please do.
Can you see my slide?
Beautiful. Yeah, beautiful. We can see it clearly.
Okay, okay. Check. Okay, can you see my slide? It's very clear, right? Okay. So today is my pleasure to be here, and this is my first time to talk for your society. Okay, today I will talk about the management of endometrioma. To remove or not to remove, I think this is very challenge topic. Okay, and this is my hospital. Okay, it is old palace. It is already 110 years old. It's in Prajinburi, small city in Thailand. It's not too far from Bangkok. It's only 2 hours from Bangkok. So next time, please visit our hospital after the COVID. Okay. And this is, I would like to share the situation of the COVID in Thailand. This is the stat for today. We have only new 6 cases. And today we don't have a death case in Thailand. And total since the pandemic, we have only 59 cases that dead. Okay. So that means today in our country, the COVID pandemic is very quiet. And now we open for some foreigner to come to Thailand to stay for 1 year or 2 years or long stay. So we are very welcome. If you want to come to Thailand, please let me know. Okay. Okay. And today I don't have any financial conflict of the interest. So I think this is very challenging topic. Remove or do not remove. I think same as when you ask the fan who is the best football player for this era, Messi or Ronaldo. I think Professor Carmona will say Messi because he is in Barcelona, and I went there and stay with Professor Carmona for a few days to learn from him about how to do the operation, how to see the patient. So he's my mentor. Okay, and I would like to share. This is the statement of the ASRM, American Society of Reproductive Medicine. So what is the endometriosis? Endometriosis is a chronic disease. This is very important because we plan to treat the patient. It's a long term because it's a chronic disease. So we need the lifelong management plan. Remove, not remove, medical treatment for or whatever. Okay. And endometriosis is a medical disease with surgical backup. This is also very important because sometimes the doctor will think, hey, when you have the endometriosis, you have to go to the operating theater. But actually, it is not. It is the medical disease. with surgical backup. So we reserving surgery for those having large endometriomas or palpable disease that fail to respond to the treatment. This slide very, very important. Okay. And why do we treat the endometriosis? Yes, of course, today we talk about the infertility treatment, but actually there is other symptoms about the endometriosis. Pain, Professor Kamuna already talked about the pain, dysmenorrhea, dyspareunia, dyschezia, or even it's turned to be chronic pelvic pain. If we not treat proper, the patient will suffer for the long life. Why do we need to treat the endometriosis? Because the infertility is very, very often in the endometriosis patient, even a primary or secondary infertility. The third one is about the mass effect, the bulky symptom, and the complication of mass, for example, rupture cyst, leakage, or even infection. And the last one is also very important, the malignancy. If the patient have the mass, they would like to know, is it cancer, right? When you think about yourself, if there is something different or abnormal in your body, the first thing that we think is it malignancy or is benign? Same as the patient, they want to know, is it malignancy? We know that the transformation from endometrioma to the clear cell is not often, but who knows, right? So malignancy, suspected malignancy is very, very important for the patient. Okay. And the endometriosis affect the patient different from their life impact of their age. For example, for teenager, 16 to 24, is impact on social life, sexual relationship, physical impact, and psychological impact. So the main thing for that time is about education in high school, in the college, or in the university. But when they are older, 25 to 34, sexual relationship it is the first priority. The second one is psychological impact, physical impact, and social life. And this time is work life. So life opportunity is very, very important. If the patient have the problem about the dysmenorrhea, maybe they cannot work very well for that time. So they lost the life opportunities. And when they are older, physical impact is the most important thing. They have to pay for the treatment cost. So financial impact is very, very important. So this is the potential contributor about the life cost impact of the endometriosis. Is this a pain? Is this impact the education, sexual dysfunction, psychological comorbidity? Impact of the relationship is not only for the couple, but for the whole family or your friend or the social. Okay, economic burden. The patient have to pay for the treatment, for the surgery, for medical treatment. Sometimes they have to pay for the IVF treatment, and also for the indirect cost. For example, they have to business leave to take care or go to see the doctor. And of course, infertility and pregnancy outcome. This is very important, and this is the topic for today. Impact of the multiple surgery and the complication of the surgery. I know that today we have a lot of the surgeon. We are the good surgeon. We are the great surgeon. But even we are the great surgeon, the complication can occur. Any surgery it can happen. So if we can avoid the surgery, that's good for us and it's good for the patient. And the last one is a comorbid disease. For example, there is some data about endometriosis and heart disease, endometriosis and osteoporosis. This is so that means it's a long life plan and long life problem for the patient who has the endometriosis. Okay, this is some data that show it's not the endometriosis not impact only for the infertility, but it's also impact the pregnancy outcome. This data show that if the patient have the endometriosis, the rate of miscarriage is increased. So we have to do something. Okay, and this is why do we treat the endometrioma. The first we talk about the endometriosis, but now we specific in endometrioma. The Professor Kamuna said there are 4 types of the endometriosis: peritoneal endometriosis, endometrioma, deep endometriosis, and adenomyosis. But I will talk only endometrioma. It can cause a dysmenorrhea, chronic pelvic pain, infertility, mass symptom, and malignancy. By the way, this is very, very important. There is some data of Professor Chapon. The endometrioma is not come alone. They come with their friend. Most of them, they have a peritoneal endometriosis. There is a DIE. There is adenomyosis. They come with a bundle. So this is very, very important. When we ask, should we remove the endometrioma? We have to ask again about, are there any disease? Are there any complication? For example, there is a DIE with a complication. There is adenomyosis and there is a symptom. We have to see the patient. It's not only the endometrioma. Okay, and why do we treat the endometrioma? This is the recent most updated paper from China, the effect of the endometrioma and its surgical excision on infertility. If we know the mechanism, that's why the endometrioma affect the infertility, now we can understand and we can plan the treatment for the patient. We know that in the endometrioma, we have the iron and we have the inflammatory molecule. That's toxic. That toxic the oocyte, that toxic the sperm, that toxic the endometrial tissue, that toxic the environment in the peritoneal. So that if we remove it, it may be benefit for the patient who have the infertility. Okay. Now we back. Why should we treat the patient? This is a Prince Mahidol. He is the father of a medicine in Thailand. He said that I don't want you to be only a doctor, but I also want you to be a man. That means we have to see the patient. It's not a disease, but it's a patient. So we have to look at the body. That means the disease, endometriosis. Mind, how they think about the endometriosis that impact their life. I mean for the psychology support. And also their soul, their family, their social. Because we treat the patient, it's not the disease. And this is the paper from Professor Versellini. Okay, he said the management of the endometriosis, moving to problem-oriented and patient-centered. This is the same thing. Prince Mahidol said that 100 years ago. And now there's some paper, I'm not sure when it's published. Okay, in 2015, 5 years ago, Professor Versellini said, we moved to patient-centered. So now we have to personalize tailor-made treatment for each patient is very different. Okay, and this is the evidence-based medicine concept that consists of three components: the best available evidence, clinical expertise, and patient preference. If we combine three components, we can do the best for the patient. For example, what is the best evidence? There's a meta-analysis, RCT, case series, and also the case report. About the endometriosis and endometrioma, I would like to specify on endometrioma. It's very difficult to do the RCT because sometimes we have to do the surgery. The different surgery, the different surgeon, the different method is a different outcome. So it's very, very difficult to do the RCT. But this is my opinion. Okay, someone said, oh, we can do the good RCT. But in my opinion, it's quite difficult to, how we say, to compare the skill of the surgery. Okay, and how about the clinical expertise? Of course, we know if the laparoscopist and the IVF doctor, they do the surgery, it's different outcome. And sometimes because it's different school of thought, the concept of the treatment is different. For the laparoscopist, maybe they prefer to do the surgery. For the IVF doctor, they prefer to do the IVF. So this is very, very different. And how about the patient preference? We know that the age of the patient, the previous treatment, the symptom of the patient, pain, mass, infertility, malignancy, and also the insurance. Who will pay for the treatment? Sometimes the patient have to pay by themselves. Sometimes there is the public insurance. Sometimes it's a private insurance. This is very, very important because I said that we have to see the patient. Sometimes they don't have the money to do the IVF, so we have to do the surgery instead, right? Okay, now remove or do not remove. Okay, we have some data that endometrioma as possible cause of reduce the ovarian reserve in women who has the endometriosis and endometrioma. This is a classic paper from Mr. Kitajima. 10 years ago, he conducted this research. Sorry. Okay, we know that if there is a endometrioma that I told you in the previous slide, there's a lot of the toxic. He called it is the burnout hypothesis. When there is the endometrioma is like the gunpowder is damaged everything, especially for the oocyte number and quality. So if we remove the endometrioma or chocolate content, maybe the benefit of the treatment is for the patient. Okay, and this is a very good paper for last year by the endometriosis treatment Italian club. I think the captain of this team is the Professor Versellini. He said, do not remove small endometrioma diameter less than 4 centimeters with only improve the likelihood of conception in infertile patients scheduled for the IVF. This is the high quality of the evidence and with strong suggestion. If we have the small endometrioma, most of the evidence, most available evidence said the patient should go to do the IVF. I will show you why. And the second one is do not leave the women undergoing surgery for the endometrioma and not seeking immediate conception without post-operative long-term treatment with estrogen and or progestin. This also the high quality of the evidence and strong suggestion. I will show you if we have enough time. Why? Okay. And this is the third one. This is how we should remove the endometriomas. The first question, remove or do not remove. But actually we have more questions. How do we move the endometrioma? We have a lot of the technique. We can do the excision, is a cystectomy, aspiration by the needle, or even by the laparoscope. We can use the ablative technique. We can use the bipolar. We can use the CO2 laser, the technique that Professor Kamuna is the expert. We can use the plasma energy vaporization. And we can do the hybrid technique. We can combine everything. We can use the cystectomy and ablation. We can do the aspiration and we do the two step. After that, we can give the GNRH agonist for 3 months and then we can do the cystectomy. So we can combine. If we understand the mechanism of the endometrioma that affect the infertile patient. Okay. And this is also very important. It's not only how we about how we remove the cyst, but the technique to remove the cyst is very, very important. For example, you have to do is very gentle. We have to do the less coagulation because if we do more coagulation, it's more trauma to the oocyte, right? If we do like a lot of the stripping and there is the bleeding, we have to do a lot of the coagulation. At the same thing, we destroy the oocyte tissue. So this is the good technique to do the surgery. Okay, and why we should to use the laser? This is I start to use the laser to treat the patient who has the endometriosis. Okay, because of after we do the endometriosis, if we do the stripping a lot, we lost the oocyte. But if we use the laser, we can preserve a lot the oocyte. Okay, this is some video I would like to show. This is mine. I also use the robotic. Okay, in my hospital, this is controlled by voice. And this is the video of the laser. This is the technique of the how to use the laser for vaporize. Okay, I will show some of the video. So this is how to use the laser. After we suction, okay. After we suction the chocolate content, now we use the CO2 laser to ablate all of the cyst wall. Is take a time, but I think is very effective for the patient because they want to pregnant, right? So we have to preserve the oocyte tissue. Okay. Okay. And this is some technique about ovarian wrapping, because we know that if we do the surgery and if we do a lot of the coagulation or suture, maybe we destroy the oocyte. So sometimes I use the ovarian wrapping. No suture, just wrap it and make it as the same as before the surgery. To prevent the adhesion and less trauma than suture. Just wrap it, okay? You can see. Okay. And why we should do the question, who should do the procedure? Because I say that the different surgeon is a different outcome. This is the paper from Taiwan, okay? They said when the expert and unexperienced surgeon is the different outcome. You can see the surgery who do by the unexperienced surgeon, the life-born rate is different, right? You can see, okay. And why should we do not remove the endometrioma? In the previous, we talked about why we should remove the endometrioma, but now we should, why do not remove the endometrioma? Because we know that if we do the surgery, we lost the oocyte, we lost the ovarian tissue, and we can know that by serum AMH is decreased after the surgery. Okay. And if we do the surgery after that, the spontaneous ovulation is decreased. It's significantly lower after the cystectomy. And now you can see if the patient go to the IVF after the surgery, they have to use more the FH unit. Okay, they got less oocyte, so that's why we do not remove the endometrioma. Okay, and this is our opinion from the Dr. Polisos from Belgium. He said that in endometriosis patient who already do the cystectomy, they become the poor ovarian response. So this is very important. I think, in my opinion, the technique of the surgery is very, very important. And the effect is not short term, but it's also the long term, because after we do the cystectomy, we destroy the cortex. And sometimes we use a lot of the coagulation. So we lost the blood vessel. That means the ovary had the less of the blood supply. That means we loss of the oocyte. I don't have enough time to talk about the experience in my country. I would like to move very fast. Okay, and now how about the question after remove the endometrioma or do not remove the endometrioma? Can we change? When we remove the endometrioma, when, why, how, and who to perform the surgery to remove the endometrioma? I think we have to change the question, remove or do not remove. Okay, and this is my last slide. I would like to say again that for the doctor, don't only see the disease, but you have to see the patient. Thank you.
Thank you very much, Dr. Olarik, for that beautiful presentation. Thank you. Well, Dr. Olarik started by inviting us to Thailand, and especially to his hospital, which I'm sure one of us should be able to take one of these days. Thank you.
he also did a very nice introduction using a very popular issue,
sure.
that
sure
of football. Okay. That of football, to describe succinctly the controversies surrounding surgery for endometriomas. He told us about the reasons for operating, the physical symptoms of the patient, socioeconomic and mental issues that surround the disease, and also the need for medical treatment. They took us to the issue why we should not operate, that complications from the operation, and particularly loss of ovarian tissue, which is obvious when you look at what can happen, especially when you have the disease affecting the ovary, which is the commonest side. But when it is necessary to operate, he told us about the methods of treatment, which are dependent on available evidence, the preference of the patient, because we know that patients do have a lot of say in this matter, and also about the available expertise. And in fact, that I penned down a question for him because he showed us laparoscopic treatment. What about open laparotomy, especially in resource poor situations? And then, of course, when we are also operating, he told us what to do. First, we must not be frivolous about just removing endometrioma because it is there. That it must also be well timed. There must be synchrony between the patient, treating the patient, and being seen at the infertility clinic. And also that we must be very circumspect. Thank you very much, Dr. Olarik. I'm sure there will be other questions for you while I hand over to the chairman of today, Professor Rotimi Akeola. Thank you.
Thank you.
Thank you very much, Pastor. Just like you said, we are just back from Thailand, and that was a wonderful excursion. That's one of the beautiful things that COVID also brought into the world. You're able to traverse the whole globe and traverse ever so quickly. The next issue we'd love to talk about, and that's because we've had a lot of things about all this. What is actually the impact of endometriosis? We've talked about to treat, not to treat, endometriomas. It's a quality of life issue and all those things. Now, it's perhaps important for us to have a 2 minute, just 2 minute physiological break, because I presume that we'll be sitting down and all that so that we can convene in another 2 minutes, and then we'll have the next speaker so that we can proceed from there.
Femi, do you want to share your slides now? Femi, hello. I'm going to.
Sorry, I can hear you, Yomi.
Yeah, can you share your slides?
I'm trying to find the slides. I'm on my iPad. Just give me 2 seconds. They are on here. 15 years. Yeah, well, it's not coming up. Yeah, to me, it's quick. So I go share content.
Dr. Ajayi, can you hear me?
Yeah, I've seen your message. I've seen your message.
Yes. Okay.
I've seen your message.
I will
Okay,
do.
it's okay.
Okay. Thank you.
Femi,
Yeah, Juwaba.
how are you doing now? Are you okay?
I'm good.
Have you been able to share it?
Not yet. So I'm on the screen and my
Is it on OneDrive?
so that it's in Dropbox, and I'm struggling to. It's in one. I can put it onto OneDrive or my iCloud drive. It's in Dropbox at the moment.
Maybe put it into another file. Maybe any other file. I think, but OneDrive is better. Try OneDrive.
Okay, let me try that. Okay.
So what I tend to do sometimes is that I put it on OneDrive or I put it on Pages.
Documents. Yeah.
Hello, let me welcome us back from that physiological break. We should be proceeding in another minute or so. We just came back from Thailand. We should be jumping to South Africa, where we have Dr. Femi Olarogun. You know that Dr. Ajayi told us, if you remember, about the role and the need for fertility preservation. So we decided to go to an expert all the way in South Africa, Dr. Femi Olarogun, who has been in this area, who has toiled diligently in this area to tell us about that. Whilst we are struggling, I think we have some technical difficulty on sharing the slide. If you permit me, I'll probably then have us move on to skip that session so that we'll get that in the background. We'll get it together in the background, and as soon as we can share the slides, we'll be able to go on to that. Or Dr. Olarogun, are you able to share now? If we still have that challenge, I would like to call on my special brother, Juwon Alabi. Juwon Alabi is one person that in a very short period, quite a lot of people already know his name. He's a consultant obstetrician and gynecologist at Sasho Women Children's Hospital in Lagos. He's the director of gynecological services, and specialist interests are in advanced endoscopic surgeries, benign gynecology, reproductive surgeries, and recurrent miscarriages. He had worked as a consultant obstetrician and gynecologist at the Liverpool Women's Hospital, Liverpool and Pennine Acute NHS Trust in Manchester, both in England, as well as St. Nicholas Hospital in Lagos, Nigeria. Dr. Alabi is a trainer in general obstetrics and gynecology with particular passion for training gynecologists in developing endoscopic and surgical skills. So I'm going to invite Dr. Juwon Alabi to do his own presentation. And like I said, that presentation basically is on impact of endometriosis on obstetric and neonatal outcomes. Dr. Juwon Alabi, the podium is yours, sir.
Well, thank you very much, Professor. And thank you, Dr. Ajayi, for inviting me to be a speaker on this extremely important topic. So I'll be talking about obstetric and neonatal outcome in women with endometriosis. And as you know, I was kind of hoping that I would be the last person to talk, because everybody with endometriosis is always about how to get pregnant, So I think I should be talking about, okay, now this pregnancy now happened. So what happens next? So I work in two places. I work in Bloom Fertility Clinic and South Shore Women's and Children's Hospital. And I'm sure you understand that they're both related to endometriosis. I live in Lagos. And if you live in Lagos, you will understand these two slides. So I welcome our viewers to Lagos as well. And this is what nightlife looks in Lagos. Well, in some part of Lagos, contrary to a lot of things that are being shared around the world, really. But most importantly, you will see this as well, which is, I think Lagos is known a lot for this picture, which are the yellow buses of Lagos, really. So I absolutely have no disclosure. I have nothing to declare today. And I mean, I want to believe that everybody has been following this lecture. So I'm going to just glide very quickly through the introduction, which is what is endometriosis? Presence of endometrial gland and stroma outside the lining of the uterine cavity, commonly found in women of reproductive age. It's contrary to initial thinking, it's found in all ethnic groups. Prevalence is about 1 in 10, but that's debatable, and but higher, very higher in women with fertility, almost as close to 30%. So if you know and if you treat a lot of these women, you will understand this as well. There are many theories for why people have endometriosis. We don't completely understand it totally, because one theory doesn't completely explain all the endometriosis we have. So the most popular ones are the telomic metaplasia and the stamp. But there are other ones like immunological, lymphatic and vascular, and progesterone resistant, and genetics is coming into play as well. So I think if we're talking about endometriosis, a lot of people will not be talking about obstetric and neonatal outcomes. I remember when I was given the topic, I was like, oh, there's not a lot to talk about this, but I think that sharing this lecture will probably change our mind as well. So when we're talking about endometriosis, we talk about infertility, pelvic pain, pelvic period, painful sex, and bowel-related symptoms. And particularly in our society as well, we see another syndrome, which is quite common, which is hemorrhagic ascites with endometriosis. Now, the professor that gave the first talk talked about 4 different types of endometriosis. A lot of people sometimes don't know whether to classify adenomyosis as its own entity or part of endometriosis. But I'm talking about endometriosis here as a 3 group, which is peritoneal disease, ovarian endometrioma, and deep endometriosis. But we also know that deep endometriosis particularly is associated with adenomyosis, which means that, the main thing is that if you're looking for obstetric outcome, you want to, I guess the layman will say that, okay, so you have this peritoneal endometriosis, but how does it affect something that is in the womb? Same to ovarian endometrioma as well. I suppose ovarian endometrioma, the mainstay will be fertility issue. But when we start coming into deep endometriosis, then you start talking about, okay, how does this impact, or the treatment of it? So there's so many studies about outcome of endometriosis in pregnancy, but a lot of the studies have a lot of bias and confounding variables. For example, what was the diagnosis? How was it diagnosed? The gold diagnosis or the gold standard diagnosis for endometriosis will be to do a laparoscopy and take a biopsy. But a lot of studies don't have this. But I do appreciate that a lot of now, hopefully we're moving to a position where a lot of expert ultrasonographer can diagnose endometriosis without biopsy. Now takes me to the effects. So what exactly are the effects of endometriosis on pregnancy? I remember in medical school, even maybe in a couple of years after when I started training, a lot of my senior colleagues or consultants will say, oh, when that woman gets pregnant with endometriosis, endometriosis will settle down. So that was the concept at the beginning. But now I think the fundamentals are changing because although majority of women with endometriosis will certainly have smooth, uncomplicated pregnancy, but it's now showing by a lot of studies that it is not so in some group of women as well. And also, we know that if you have endometriosis, complication of the endometriosis can happen while you're pregnant, irrespective of the pregnancy as well, especially things like intestinal obstruction and bowel perforation. Appendical endometriosis can lead to symptoms of appendicitis. Or sometimes the uterus might rupture. I'm sure a lot of the obstetricians maybe on this platform might think about this a bit and say, okay, this woman has never had surgery or any medical issue, or particularly surgery, but they have a ruptured uterus. Maybe we need to start thinking about that now. So in my, so I looked for the evidence. I looked for things that we can, I have two papers here, and they're both recent papers. One is the one on the obstetric complication of endometriosis, particularly deep. It's a meta-analysis, and I'll come to the figures. And the other one is endometriosis increases the risk of obstetrical and neonatal complication. They're both recent papers. I think one of them is 2009, and the other one, I think, is 2017. So let's go to the first one, which is from a group in Italy, where they compared, if you look at, I think they look, it's a meta-analysis. That means they look at all the papers written on outcome of endometriosis, and they found that, let's see whether, okay, so they found that there were so many variables, and the particular thing they noticed was that I think women with deep endometriosis seems to have the more adverse outcome compared to peritoneal endometriosis and ovarian endometrioma. And I will go into details as well eventually, but they looked at things like preeclampsia, placenta previa, miscarriage, antepartum hemorrhages, uterine rupture, and so on. And then we will come to that. Now, the second study is from Denmark. So what they did was that Belak and his group and her group, they looked at all the deliveries in Denmark for a few years, I think about 30 years. And I think they were able to get 61,000 deliveries. And they looked at the number of endometriosis in them, and they were able to get the outcome. I'll come to that as well. And the last one is this one that is, I think this is the most recent one that came out of Canada, which is endometriosis and adverse maternal, fetal, and neonatal outcome, a systematic review and meta-analysis. Out of the papers I have just shown, I think this is probably the most concise and also the most detailed. So what they did was that they were able to get 33 studies, and the sample size was 3,280,000. So the conclusion from that is that in terms of comparing endometriosis, women with endometriosis and women that do not have endometriosis, they found that women with endometriosis have a higher odds of having preeclampsia, gestational hypertension, gestational diabetes, antepartum hemorrhage, malpresentation, and cesarean section, both emergency and elective. And it was also shown that the fetuses or the neonates of these women were more likely to have premature rupture of membranes. They were more likely to be admitted to the NICU. They were more likely to have neonatal death, specifically because of the, probably because of the preterm. Also, they also were able to find that there was a high level or a higher level of placenta previa in these women as well. So, and also things like placenta preta as well. Now, this is a study. I mean, this is the study. This is Lalani as well. So I think just a breakdown, just like a summary as well. So these are the things they found: preeclampsia, gestational diabetes, placenta previa, cesarean section, preterm delivery, prolonged preterm rupture of membrane, small spot gestational age, stillbirth, and neonatal death. Another group from Italy were able to find that placenta previa seems to be common in women that have endometriosis. And although they were trying to postulate why that happened, as we know, if we look at the causes of placenta previa, I mean, this is whether the person has endometriosis or not. These are causes of placenta previa, or theory. So damage to the endometrium, damage to the myometrium from surgery or infection, any process that prevents migration, impeding endometrial vascularization due to poor blood supply from hypertension, diabetes, and the first three of these can be related to endometriosis, really. Endometriosis in conjunction sometimes with adenomyosis can cause damage to the endometrium. Endometriotic surgery sometimes as well can cause, especially with the deep endometriosis, can cause some damage to the myometrium, and that can cause issues as well. Now, this is a study that was done in Scotland, also looking at the incidence of looking at the pregnancy outcome of their pregnant lady. I think they were able to get this was over 30 years. They were able to get 14,655 women, and 5,000 of them had surgically confirmed endometriosis. When they compared both, they noticed that the women that have endometriosis have a higher risk of pregnancy loss and ectopic pregnancy, placenta previa, unexplained antepartum bleeding, postpartum bleeding, and preterm birth. Another finding is from this group as well, where they were able to demonstrate exactly the same conclusion. Endometriosis is associated with higher risk of cesarean, postpartum hemorrhage, and the use of heterotonic agents and blood products. Now, what they did was that they also looked, I think this was if I'm right, I think this was the Danish study. They looked at 61,535 deliveries. I think their number of endometriosis was a bit small for that group, but that's what they recorded. And what they saw was that they have a higher rate of induction of labor, cesarean section, postpartum hemorrhage, placenta accreta, blood transfusion. They found no difference in neonatal outcomes. Another big data from South Korea, which they looked at a total of 3,778,000 women who gave birth between 2007 to 2015. They practically came to the same conclusion as well. Higher incidence of multiple pregnancy. I think that, so this group, there was no differentiation between ART and spontaneous birth, pregnancy. So I guess the ART part gave it a lot of multiple pregnancies. Cesarean section, breech, postpartum hemorrhage, placenta abruption, placenta previa, stillbirth, preterm birth, and low birth weight. Another big study, similar findings. So I won't really go into that. So this is another big group. Okay, sorry, this is Denmark. The other one was, I think, Finland. 19,331 delivery by 11,739 women with endometriosis. The unexposed cohort was 615,000. Same findings, all severe preeclampsia, bleeding in pregnancy, placenta abruption, placenta previa, premature rupture of membrane. So their conclusion is that endometriosis increases the risk of obstetrical complications and adverse neonatal outcomes. The magnitude of this complication calls for increased attention and surveillance of women with endometriosis during pregnancy. I think my take with this is that there's so much focus on infertility and endometriosis, and sometimes we apply science by the fact that once they get pregnant, they are being managed as high-risk pregnancy as well. Particularly, some of them get pregnant with IVF, so for them, probably it might be their only chance of pregnancy. And also, I think even the ones that get pregnant spontaneously, evidence shows that they have to be managed as high-risk patients in pregnancy. So the problem, how do all this complication happen? So the first one is that there is a thinking that altered uterine contraction happens because of endometriosis. There's abnormal contraction which affects the location or the site of implantation of the blastocyst. It's also due to, the multiple pregnancy, we've explained that the altered utopic endometrium causes a lot of hostile or inflammatory response, and we all know that endometriosis is a chronic inflammation. So that increases, when you have a chronic inflammation process or an inflammatory process and a woman is pregnant, then the combination might not be favorable, especially in terms of preterm delivery or irritation to the uterus. Now, we also know that increased history of uterine trauma from increased pregnancy loss or even from surgery can affect altered placentation. Now, another explanation for this can be that when you, for the last one, can be that women with endometriosis can have an associated adenomyosis. And adenomyosis are almost like a trauma to the myometrium and causes inflammation as well. So that can cause abnormal placentation and preeclampsia and all the problems that comes with preeclampsia. So, which was what I'm trying to explain here. In endometriosis, functional and structural abnormality in the junctional zone in MRI and biopsy have been shown that endometriosis patients have associated adenomyosis, thereby defective transformation through the spiral artery, obviously leading to preeclampsia, intrauterine growth retardation, preterm labor, and placenta abruption. And I've explained this as well, so I'll just move very quickly to the next slide. I've discussed this as well. The inflammatory nature of endometriosis may be the cause of the high incidence of extreme premature delivery, regardless of parity or plurality. Now, another factor is iatrogenic because cause of placenta previa, which is sometimes we are worried about preeclampsia, so we want to deliver early, and that leads to preterm labor and obviously, and all the associated problems that come with preterm labor. Preterm delivery almost likely that can explain the highest neonatal death in this group of women. Now, there's also good research because there's a subgroup. So you have people that have endometriosis, and you have people that have endometriosis but have never had surgery, and then you have people that have endometriosis and have had surgery. The evidence shows that in these women, they have a higher incidence of adverse outcome compared to the women who probably have never had surgery. So I guess maybe when we're thinking about what we should be offering these women during counseling, then it might be important to bring all this into the picture as well, because sometimes when we counsel women for surgery, we limit ourselves to infertility and improvement of fertility. Meanwhile, I think we should be talking about the obstetric outcome to these women as well. But it's also thought that in that aspect, it might not necessarily be that the surgery is the problem, but a surgery, you actually may do surgery more for people with severe disease, so that you extrapolate. It means that the abnormality, the adverse outcome in this group is because of their severity, the disease severity. So very shortly, my conclusion is that endometriosis does not only cause infertility and pain, but it also causes adverse outcome when pregnancy eventually occurs, either spontaneously or through ART. So I think it's important. There's the notion that I mentioned at the beginning that if you have endometriosis, a lot of doctors will say that, oh, don't worry, just get pregnant, everything will be fine. But we're now knowing with good evidence that it is not so. That is they've managed to cross one part of the journey and they're getting to the next part of the journey. So it is important that they are managed by obstetricians that understand this concept, and also in centers that have good neonatal intensive care units. I think it will be very painful to be able to get a woman pregnant after many years of fertility, and then they got pregnant and they lose it, or have preterm, extreme preterm, and cannot be managed properly. So I think with that in mind, I think I've been able to tell you about the adverse effects of endometriosis and pregnancy. I think it's important now when we see women with endometriosis, we think about the obstetric outcome as well. They have a high incidence of preeclampsia, high incidence of placenta previa because of the probably damaged myometrium or endometrium. They have a high incidence of abruption, high incidence of antepartum hemorrhage, postpartum hemorrhage. Now, the postpartum hemorrhage is explained sometimes by the placenta previa or the placenta accreta, where they also have retained placenta as well. So thank you very much. I think I've gotten to the end of my talk, very short, but very, I think I have been able to put all the evidence in that short talk. Thank you very much.
Thank you very much, Dr. Ajayi, and that's actually been very, very wonderful. When you started out, and I could understand that you said, I mean, we were talking about the whole idea is usually when you have endometriosis, we are talking about infertility and how to manage infertility and all that. But just like our friend from Taiwan, Olarik, told us, there's a fact that we must recognize the fact that quality of life, infertility metrics and all that, all the quality of life metrics that are concerned, infertility is just one of them. And therefore, so when you talk about all these things, now if the person now gets pregnant, what is the effect on the mother during the pregnancy and what's the effect on the baby? You see, there are lots of questions that will arise subsequently from this. But Dr. Ajayi has been, Dr. Juwon Alabi has been able to tell us about even uterine rupture taking place simply because of endometriosis. He's been able to tell us about abnormal placentations, preeclampsia. He's told us about placenta previa. He's told us about increased incidence of cesarean section, possibility of abruptio, prom in children, NICU admissions, preterm deliveries, low birth weight babies, and perinatal deaths. So bearing all this in mind, you find out that he had imagined that he was supposed to wrap up the whole session when everybody has talked about the butchers and the butchers and those that have done their job and gotten the women pregnant. Not to talk about after that getting them pregnant, what then can arise. I think by now we'll have sorted out Dr. Olarogun's slides, and we'll then be able to bring them on. Dr. Juwon Alabi, thank you very much for your wonderful presentation. Let me ask the pastor, Professor Udukogbe, again, to bring on, to take us to South Africa, where we'll meet with Dr. Femi Olarogun, telling us about this fertility preservation. Thank you very much.
Thank you, my president. We've had some rest, and we've also been treated to what Dr. Alabi thought to be the desert. But anyway, at times it is not, there's no problem. You can at times take some dessert and then take the full meal. All will be processed by the stomach. So now we move to South Africa, like it's been said, and I'm going to introduce Dr. Femi Olarogun. Am I right?
Olarogun, that's all good.
Olarogun, okay. Dr. Femi Olarogun is a reproductive medicine and surgery subspecialist at Heart Fertility Clinic, Cape Town, South Africa. He obtained his MBBS degree in Nigeria in 1990, and in 2010 had his fellowship of the College of Obstetrics and Gynaecology certificate in South Africa. He practices in the private and public sectors in Cape Town, as well as Windhoek in Namibia. Dr. Olarogun has been the head of the firm for the reproductive medicine unit at GS Hospital of the University of Cape Town since 2010. And he also served as a visiting lecturer in Botswana and in Nigeria. Yes. For cases of endometriosis, fertility, as we've seen this afternoon, plays a vital role. And we also know that generally worldwide, women are delaying pregnancy, when to get pregnant, to later ages because of several issues. So, and then of course, there are some who are also who will do this for other reasons, like if they have a coexisting cancer. So this afternoon, Dr. Olarogun will be telling us about fertility preservation in endometriosis. So please welcome Dr. Femi Olarogun. Thank you.
Thank you so much for that very kind introduction. Sorry, and I apologize to the audience for the initial hiccup we had, but we seem to have been able to make a plan. And hopefully we can get through the next 20 minutes talking about fertility preservation with no problems. I would also like to thank Yomi for inviting me to be a panelist on this very exciting sort of initiation. And if you look behind me, I'm actually sitting in Hermanus, which is about an hour and a half from Cape Town. And you can see the Green Mountains behind us here. This is one of the, the things you get in Cape Town. Hermanus is just one of the cities in and around Cape Town. And there are so many of them, that one could visit, not to mention Cape Town itself. And obviously we'd like to, invite everybody here when COVID allows us to travel, to come out to Cape Town and enjoy some of what we have to offer. So my brief in the next sort of 20 minutes, like I said, is to talk about fertility preservation, endometriosis. And I would like you to see fertility preservation as not one entity, but a continuum. So a number of things that can be done. And in that same vein, I would like to apologize to the audience because I think a lot of what I'm going to say has already been mentioned by some of the panelists earlier on. So there will be some repetition in what I'm saying. Can I have the next slide, please, Jenny? So as we know, endometriosis is a condition characterized by ectopic endometrial implants throughout the pelvis. We know it negatively impacts fertility and reproduction, but does not usually completely prevent pregnancy. In fact, about 30 to 50% of women with endometriosis are thought to have infertility. And in women presenting with infertility, 25 to 50% are estimated to have endometriosis. Those are quite significant figures. So if you're seeing an infertile woman, there is like almost a 1 in 2 or 1 in 3 chance that she would have endometriosis. We can understand why endometriosis causes infertility in the severe cases. Next slide, please. Thank you. So if you look there, that's a severe case of endometriosis, and this is easy to understand. I hope that projects nicely. The tubes are twisted, they're torted. The bowel is attached to the back of the uterus. The ovaries are in different positions, and they're almost, so there's fibrosis, there's adhesions. So you can understand why that pelvis would not be conducive for pregnancy. And the milder cases where you have just a few spots of endometriosis, in the pouch of Douglas or around the ovarian fossa maybe, it's a little bit more difficult to understand, but it's thought that there are cytokine pathways that actually go along with the presence of those mild to minimal endometriosis that then causes or makes the pelvis, relatively infertile. So that's why we think, endometriosis is an issue. Next slide, please. So when we're thinking about fertility preservation in this patient, and this has been mentioned before, but it's good to reiterate this, a number of factors have to be considered. So you can't look at it as the patient has endometriosis, she needs fertility preservation and that's it. You have to consider the age of the patient, the severity of the disease. Are we talking mild, moderate disease or stage 3 and 4 disease? Has this patient had previous surgery? Does she have ongoing pain? And are there other indications for ART? So in other words, if this patient is exposed to a male factor, for instance, in other words, there is, oligospermia, you are already looking at IVF. You don't want to waste time, you probably go straight down that line. If you have a tubal disease from other conditions, you're probably looking at IVF straight away anyway. The age of the patient, the closer she is to going to try and get her pregnant as soon as possible rather than try and preserve her fertility. So there's a number of things that one will look at, when you're considering. As we know and has been mentioned, surgery, usually in the form of laparoscopy, is the cornerstone for diagnosis and treatment of endometriosis. Now, while there's enough evidence that it improves fertility potential, it could also decrease ovarian reserve and affect pelvic function, especially if there's ovarian involvement. So as we know, even when you don't have ovarian involvement, you have sort of stage 4 disease, you can have affectation of fertility. But when you do have ovarian involvement, operating on those ovaries, operating on the pelvis could do more harm than good. So the disease itself is a problem in terms of what it does as far as fertility is concerned, but the form of treatment that we offer, it's a surgical form of treatment that we offer, could also be a problem. So when you're talking to a woman who is presenting to you with endometriosis and infertility, and you're thinking about surgery, you need to think about it carefully. And that has been alluded to. You might even want to consider IVF first, and we'll talk a little bit about that. But the one that is probably more important is repeat surgery. There is no role for repeat surgery in a patient with endometriosis if the main indication is infertility. If it's pain, it's a different story. But if it's infertility, there is, provided obviously that the first surgery was done properly and done in a unit that obviously deals with endometriosis all the time. You don't gain anything by going back to reoperate. You probably will be losing something. And just the last point there just mentions that if there is symptomatic endometriosis in patients with infertility, we don't know how this affects these patients, and these patients should not be operated on. Next slide, please. Yomi, next slide, please. Thanks. So what is fertility preservation? No, the one before, Yomi. Yeah, thanks. So what is fertility preservation? Refers to the process of trying to conserve future fertility potential in women where this may become a problem later. The obvious ones, as we know about, are patients who need chemotherapy or radiotherapy from cancer. Some medical disorders, serious medical disorders also require some kind of chemotherapy. Women who want to delay starting a family because they have other things that they need to do first. And also in women where pelvic pathology is likely to affect fertility potential. Example, like we've just mentioned, is endometriosis. The most commonly used technique is cryopreservation. That's relatively easy. It's a freezing of oocytes. These patients undergo a normal standard IVF cycle. The eggs are retrieved as we normally do, and they are frozen, and they could be kept for a long time. You could obviously also freeze embryos if the patient does have a partner or a male partner in mind, or probably even using donor sperms. You could also freeze embryos, which obviously freeze a bit better than oocytes do, and less commonly ovarian tissue. So there's been some, literature about, taking off the cortex of the ovary and having that frozen, and using that later on by reimplanting in the pelvis and trying to use that. That's probably not a very feasible thing in endometriosis for obvious reasons. If you have ovarian endometriosis, it's difficult to get to the cortex or get enough normal cortex. And when you try and reimplant as well, it could also be an issue. And like I've mentioned, you do have the ability to cryopreserve oocytes and embryos for quite a while. Next slide, please. So, fertility preservation and endometriosis, we do know, like I've mentioned, that in women with gonadotoxic therapy who are going to have gonadotoxic therapy like chemotherapy and radiotherapy, it's well established that cryopreservation of oocytes and embryos are offered standard to this patient, but they should be offered to these patients. It then becomes attractive in patients with endometriosis, as we know endometriosis, and like I mentioned, and its surgical treatment is associated with ovarian depletion and also infertility. Unlike in oncofertility, where there is a bit of time constraint, in other words, where you got to go in within a couple of weeks to try and get those oocytes or those embryos sorted out before the woman goes for chemotherapy, there is a bit more time to play with here. It's usually pain that can be controlled, and you can plan and have a discussion properly. Patients with ovarian disease, however, pose a unique problem, as surgical treatment almost always affects ovarian reserve, and that has been mentioned. I will mention a little bit of that in the next couple of slides. Next slide, please. So the first report of cryopreservation in endometriosis was in 2009 by Eliezer, and he retrieved 21 oocytes over 3 cycles in the same patient from a 25-year-old patient. And then Garcia Velasco et al. In 2013 reported over a 5-year period fertility preservation, in fact, cryopreservation of oocytes in about 38 women. Since then, there's been numerous reports of this treatment being offered to endometriosis patients. Lots of papers have been written. Donnet et al. In 2005 spoke about ovarian cortex freezing. Like I mentioned, it's not standard practice for most units. Most units will just do cryopreservation of oocytes and embryos. Probably the largest paper published to date is by Kobo et al., which was published in the Fertility and Sterility in 2020. And they reported 10,044 women that were diagnosed with endometriosis who had egg freezing, and 43% came back for thawing. So it gives you an idea what percentage of these patients who have had their eggs frozen for endometriosis comes back. But this was within like an 18-month period. The success was very good. They had 46% live births. However, 39% of those who failed to conceive using those frozen oocytes conceived with fresh IVF cycles. So that tells you a number of things. The one is that perhaps, obviously, these women are young women, and they could still have IVF. In other words, maybe IVF will have been the way to go with these patients in the first place. And the other thing that tells you is that, if you do have, as backup your frozen embryos, your frozen eggs, you could still do IVF in some of these patients, as time goes on. Next slide, please. So I'm going to just talk briefly about fertility preservation in mild disease, fertility preservation in severe disease, and then we're going to focus on endometriomas, which is where I think most of this actually is. And
Hello?
like I said, a lot of this has been discussed already. Hello?
Go on, please.
Hello, can you hear me?
Go on, please.
Okay, sure. So I'm going to talk about a little bit about fertility preservation in stage 1 disease, and then in severe disease, and then we'll talk about endometriomas. So as we know, endometriosis is a chronic disease. It requires lifelong management. And the goal is to try and optimize medical treatment and avoid repeated surgery. Again, bearing in mind that the more surgery you do, the more likely you're going to convert that pelvis into a pelvis that is not suitable for pregnancy. So you want to limit the number of surgeries that you do. Primary surgical treatment in the form of laparoscopic excision or ablation improves pregnancy rates significantly compared to diagnostic laparoscopy. We know that. Odds ratio 1.94, Cochrane Review 2014. Like I mentioned, repeat surgery for infertility is not indicated. as this has been shown to not improve outcome at all. Discussion regarding early starting of a family should be had in women diagnosed with endometriosis while they are young. So this is quite an important statement, because if you have a patient presenting to you and she is in her early 20s, mid-20s, late 20s, and you've diagnosed her with endometriosis, I often get this in my practice. And you've done the surgical treatment, for the sake of argument, stage 4 disease, and you treated them. They often feel better, and they get better, obviously. But the problem is, if you wait, there is often recurrence of the disease, as we know. So you need to tell this patient that you have to try and get pregnant as soon as possible, because obviously as you get older, mid-30s and late 30s, it then becomes more of an issue, because ovarian reserve then becomes a factor as well. Next slide, please. What about stage 3 and 4 disease? Early primary surgery with restoration of anatomy and excision disease is associated with good ongoing pregnancy rates. And surgery does not have any negative effect on IVF success. So that we know. Early recourse to ART is advisable in these women. So patients with severe disease, you probably should be leaning more towards IVF sooner than later. There's no indication for long-term medical suppression following surgery. So if you do surgery in these patients and they desire fertility, there is no room to suppress them for, and this all the big bodies agree with this. There's no room to suppress them for any length of time. They should go straight into a fertility treatment or some kind of fertility program. ART may be considered prior to primary surgery, like I mentioned earlier, in cases where the diagnosis was made either clinically or on imaging. Again, I reiterate, repeat surgery for infertility is counterproductive. Next slide, please. So what about ovarian endometriosis? And this is obviously where most of the problem is. Endometriomas are often densely adherent to surrounding structures like tubes and bowel. And often when we operate, obviously we try and avoid damage to bowel and to tubes. And we tend to perhaps err on the side of maybe taking a bit of ovarian tissue. So in other words, you leave a bit of ovary on the bowel rather than leave a bit of bowel on the ovary. So already, if you're operating on ovarian endometriosis, you're talking about some kind of loss of ovarian tissue. The treatment goals we're trying to achieve here, and has been mentioned by the professor from Singapore, is relief of painful pressure symptoms, to prevent further complications like rupture and torsion, exclude malignancy, improve fertility. Now, while we're doing all this, we're aiming to preserve ovarian function and reserve. So that's at the back of our minds what we're trying to do while we're trying to, sort of work on the ovarian endometriosis. Next slide, please. So this has been alluded to already, and I'm not going to say too much about it because, but it's probably important for us to probably just reiterate that as well. There are different techniques that people use when it comes to treating endometriomas, including cystectomy, ablation by laser, and electrocoagulation. And there's always that debate about cystectomy being better than ablation in terms of prevention of recurrence and pregnancy rates and all that, which is very true. On the other hand, you worry about the more ovarian tissue or cyst tissue you remove, the more compromise you're going to do to the ovary. So a combined technique of perhaps partial cystectomy is what we favor in our unit, and coagulation at the base. So you do a cystectomy, say about 70, 80% of the cyst is removed. And when you get close to the hilum, you perhaps do a bit of coagulation there to try and prevent losing too much ovarian tissue. If you've got bilateral disease, however, it then becomes a bit more tricky, because you can, if you do them both sides, you worry about how much ovarian function you're losing. And in those cases, you might want to do a cystectomy on the one side and be a lot more conservative on the other side. It's important to avoid multiple incisions on the ovary to preserve ovarian function. So if you've got large ovarian endometrioma, you probably want to try and do everything through one incision away from the hilum, because that's where you're going to get your, sort of bleeding as well, and you want to avoid that. The next point talks about what anybody that probably does operating on this sort of cases would agree. sometimes it's quite easy to peel that endometriotic cyst away. You know, you're there and you can get there, you can do your partial cystectomy quite easily. At other times, it's not so easy because it's very adherent. And in those cases, when instead of trying to go ahead and just pull hard and, you know, try, and in which case you're going to traumatize and perhaps damage the ovary and lose more ovarian tissue, it might be pertinent to do a biopsy, coagulate, rather than try and persist with a difficult cystectomy. And while obtaining hemostasis, again, avoid damaging the blood supply behind them. And we always consider the use of anti-adhesive treatment, you know, while we're there. Again, it probably decreases your chances of having to go back and reoperate as well. Next slide, please. So endometriomas itself does not seem to alter ovarian function. In women with unilateral endometriomas, ovulation occurs at similar rates from the normal when you compare it to the endometriotic ovary. That was published by Maguire et al. In Human Reproduction 2015. Excision of endometriomas rather, improved pregnancy rates, and that was again proven Cochrane Review 2008. Excision of endometrioma hasn't been shown to improve outcome in IVF ICSI cycles. I mentioned that earlier. Ovarian surgery to remove endometrioma reduces ovarian reserve significantly if you're measuring AMH. A recent meta-analysis of 8 studies looking at cystectomy and endometrioma suggested a 30% reduction in AMH following intervention. And repeat surgery, like we've said, has a greater effect on the ovarian reserve on these patients. Next slide, please. So what's the approach to then managing an endometrioma? Women with symptomatic and growing endometrioma should have surgical intervention. If fertility is not immediately desired, suppression should be considered. Again, you limit the risk of repetitive surgery, and in that way, you preserve the ovarian reserve, ovarian function, and you preserve the fertility that way. Small 5-centimeter lesions, especially if asymptomatic, should be observed, especially in older women. So if you're a woman who's probably younger, you might be a bit more aggressive because they have a bit more ovarian function. But, you know, mid-30s, late 30s, you probably be a lot more conservative. So you don't have to operate on every endometrioma. You can treat them symptomatically and see how that goes. Meticulous surgery, that's been mentioned already, including the limited use of bipolar. Again, stripping initially a bit of cystectomy and then base ablation technique preserves ovarian reserve, and there's some evidence for that. And there's always that debate about, you know, the surgeons who prefer to operate all the time versus people who do IVF and that's all they do, whether that would be the best way to go as far as endometriosis is concerned. Now, the decision to do that should be taken only after careful consideration is given to the age of the patient, the surgical history, available expertise. So if you're in a place where you have surgeons that are good enough, maybe you want to lean in that direction. If you're in a place where cost of IVF is prohibitive to the patient, you probably don't have that much of a choice than to go the other way. And obviously the patient's wish as well. So all this needs to be taken into consideration when we're deciding on, you know, whether we're doing IVF or surgery on these patients with ovarian endometriosis. Next slide, please. Next slide, please, Yomi. So very briefly, and I'm getting to the end of my talk, just endometriosis and IVF, what do we know? There's some evidence that fertilization rates of oocytes in patients with severe endometriosis was poorer compared to those with stage 1 and 2 disease. That's self-explanatory. Women with mild moderate disease, type 1 and stage 1 and 2, have similar live birth rates to women without endometriosis, with IVF, that is. And there is some controversy as to what happens as far as severe disease is concerned. There were 3 systematic reviews in 2002, 2013, and 2015 that suggested lower oocyte retrievals, implantation rates, and pregnancy rates in women with advanced endometriosis. However, a larger meta-analysis of 78 studies, including over 20,000 women in 2014, suggested there was no difference in live birth rates in this women. Now, patients with endometrioma often have a lower ovarian reserve and produce fewer oocytes as far as IVF is concerned. So we need to bear that in mind. Next slide. So this is my concluding slide. Fertility preservation should happen at several levels. So it's not just about egg freezing and oocyte freezing and embryo freezing. It includes careful selection of surgical candidates, who should go for surgery, who shouldn't. Avoidance of repeat surgery, which takes us back to that very first surgery. Like they say, first cut is the best, right? So very first surgery is the one you want to do, and do it properly so that you try and avoid doing repeated surgeries on these patients. Careful intraoperative techniques, we've alluded to that as well. Offering cryopreservation to all women with endometriosis will be impractical to do at this point due to cost. The selective use of oocyte or ovarian tissue cryopreservation needs further evaluation. We need a bit more studies in this direction. However, women with bilateral endometriomas, previous ovarian surgery, and young age at the time of diagnosis may benefit from fertility preservation, as we discussed, and this should be considered and offered to these patients. Last slide, please. Last slide, please. So that's where we work from. That's heart clinic in Cape Town. And again, let me just reiterate the invitation to everyone who might be listening to us, that Cape Town is always welcoming. It's a beautiful part of the world, and you're always welcome to come to Cape Town to visit. Thanks for listening to me.
Thank you very much, Femi. You really made my day, because about 4 times you said there is no role for repeat surgery. Back in the 90s in Ibadan, we once saw a patient who had endometriosis, little known then, and who had had surgeries several times with infection and adhesions, and the peritoneum that should be just less than 0.25 thick, the peritoneum was about 3 centimeters thick from these multiple surgeries. So thank you for the emphasis that you placed on no role for repeat surgery. And I implore so many of practitioners, especially in resource poor countries, should take note of this. So Femi has told us about the reasons for fertility preservation. That is when you want to delay pregnancy in cancer cases and in some medical conditions, and also when you want to prevent surgery, when you want to prevent repeat surgery, especially, that you can treat the patient while you are preserving the egg. And then you also help in dealing with the numerous complaints of these patients who have the disease. He talked about the techniques, that of cryopreservation of either the egg, the embryo, or even ovarian tissue. And this can be used in artificial reproductive techniques. Well, just one question I have for you, Femi, is that I wonder, how do you determine the viability of the ovarian tissue that you are taking? And in this wise, that is why I like embryo preservation, because you are surer of getting something. So how do you, when you take a sliver of the ovary, how do you determine that this is going to be viable? Thank you very much.
Thank you very much. Thank you very much, Pastor. I think we'll just take that as the #1 question when we get to the question and answer session, because usually, you know, we left the best for the last. Those who know the passion of the convener, that's the chairman of our continuous development committee in Society of Gynaecology and Obstetrics of Nigeria. I'm talking about Dr. Ajayi. Will know how passionate he is about HIFU. HIFU is always talking HIFU. So we're talking about high intensity ultrasound management, whether it is for fire, for anything and all that. You know that we will always bring this in to consider it and talk about it. Therefore, it is actually my pleasure, because one of the experts, somebody who breathes it and loves it, Dr. Lian Zhang, all the way. And then again, thanks to COVID, we are going around the world in a few minutes, and it's so easy to do so. I'll be inviting Professor Lian Zhang to come and tell us basically about, he is a professor of at Champion Medical University in Chongqing, China, and he is medical director of the National Engineering Research Center of Ultrasound Medicine in China. He is also a standing committee member and Secretary General of the Minimally Invasive and Non-Invasive Medicine Committee of the Chinese Medical Doctors Association, and is Secretary General of the International Society of Minimally Invasive and Non-Invasive Medicine. Professor Zhang's interest in molecular biology, molecular genetics, and oncology. He's published more than 80 papers in various peer-reviewed journals. So we are inviting him to come and talk to us on yet this topic of high-intensity focused ultrasound in the management of endometriosis. Professor Lian Zhang, the podium is yours. You are welcome, sir. Please go ahead.
Thank you very much. It's my great honor to be invited to give this presentation. So first, I want to say thanks again to my friends from Africa. So about the high intensity focused ultrasound, I think it's kind of new. So first, I would like to take a few minutes to talk about this technique. High intensity focused ultrasound is a non-invasive treatment modality. This slide shows how it works. Like here, this is a transducer. The ultrasound beams are generated from the surface of this transducer and just focused at some distance away from the surface. And all the energy just focused at the small, very tiny point. So during the treatment, the ultrasound beams penetrate the human body, human tissue, and just focus at the target, at the tumor. So when the temperature increased to 65 degrees, necrosis occurred. So from the monitoring image, we can see the grayscale changes like this. So how did we treat this tumor or adenomyosis? Just like this. First, we move the transducer and just target at the lesion. Then we start to solicate. When we see the grayscale changes like this, it means necrosis occurred. So then we solicate again. You can see more changed area. Then we move the focus to the another point and solicate again. We see the grayscale changes like this. So when we treated all the lesion, when we saw the grayscale changes that covered all the lesion, then we can terminate the treatment. So this technique was first proposed by the scientists from the US. In 1940s, Lin proposed this concept of HIFU. In 1950s, Dr. Fry confirmed this technique might be used in clinic practice. So, but for a long time, this technique didn't use in clinic because there was low monitoring image at that time. So until 1980s, with the development of the diagnostic image, the therapeutic ultrasound received international attention again. In 1980s, Professor Wang from Chongqing, from our group, he started this project. So this is the first transducer he made. And you can see this black box, there's water inside, and we can see the ultrasound beams come from the transducer and just focused at the very tiny point. So we call this point as acoustic focal region. So if corresponding to the tissue, then we can see the necrosis area at here. So Professor Wang named this as a biological focal region. It means necrosis area. So when we use different power or solidicate for different time, the necrosis area will be different. So for example, like here, so it's very tiny, and this one very big. So it depends when we treat the tumor or the lesion. If this area is safe, then we want to treat it faster, quicker, then we can use higher power and solidicate for longer time, then we can achieve a large necrosis area in a short time. But when, like we treat the lesion close to the nerve or close to the endometrium, we don't want to get the endometrium or the nerve get injured. Then we can use a lower power or solidicate for a short time to just precisely ablate the lesion without damage to the surrounding structures. So that's very important. So after 10 years basic research, in 1997, this technique was first used in clinic to treat the patient. The first patient in the whole wide world we treated was a osteosarcoma. So now this technique can be used to treat different types of solid tumors, like the liver cancer, pancreatic cancer, kidney cancer, bone tumors, and soft tissue tumors. Also, uterine fibroids and endometriosis. So like this from the FAST Foundation from the US, like from here, you can see a lot of applications right now. So at the end of 2019, more than 150 applications, indications can be treated using this technique. So now I'm just focused on the come back to talk about endometriosis. So like we all know that the treatment for endometriosis is still a big challenge. So far, no single very successful option for the treatment of endometriosis. Like here, so what can we do? What can HIFU play in the management of endometriosis? So far, since like I said, this is a new technique. Now we use this technique to treat adenomyosis, has been widely used in China, and we treat a lot of cases, and it has been confirmed this is a safe modality for the treatment of adenomyosis. We tried like use this technique to treat some other endometriosis. Also, we tried like the bladder endometriosis. So now, first, I just want to share with you about my experience of HIFU treatment for adenomyosis. In 2007, in China, I treated the first case. This patient was 37 years old. Then she presented with severe dysmenorrhea and menorrhagia. Then you can see from MRI, you can see the lesion just located the anterior wall of the uterus. Then the patient, the lesion was not so big, but the symptoms was very bad. And she had severe pain, like even every month, like the 1 week before the period or 1 week after the period. So the pain score was very high. So the local doctors suggested her to have hysterectomy, but she said she just 37 years old. She didn't want to do that. So she was referred to our center. Then we tried to treat this case, but this first case, so I was not so aggressive. So you can see I use a power just like 200 watts. And the solidification time is very short. The treatment was not so long, just like almost 9 minutes and 20 seconds. So that treatment was done. It's very easy. So I was so surprised because I thought it should take a longer time. So after that, the MRI showed the necrosis area, just the surrounding structure was intact, low damage. Even this endometrium. So the patient, after the treatment, the symptoms was gone, and low pain, and the dysmenorrhea and the menorrhagia were improved after that. So after this case, we think this technique can be used to treat this kind of patients. So we start use this technique in clinic, and we start some project, clinical trial. And so for HIFU to treat the endometriosis, this principle, like the first, just like we can selectively ablate the adenomyotic lesion and minimize the adenomyotic lesion, then the uterine size can be smaller, and also like cause a function loss of the adenomyotic lesion, so to improve the symptoms. So from here is the first, like the multiple center clinical trial from 2010 December to 2011. Then 350 patients were treated in 3 centers. Then 224 patients completed 2 years follow-up. Then this is the inclusion criteria. So the diagnosis of adenomyosis was confirmed by MRI for all patients. And the wall of the uterus was thicker than 3 centimeters because we want not so small for the safety reason at that stage. So all the patients, they didn't want to have a hysterectomy, and we enrolled these patients. So this is baseline characteristics of these patients. You can see the average age around 41 years old. Here is about the size of the adenomyotic lesion, just around 5 centimeters in diameter. And also this is about the volume. We just calculate like this, and this is about the size of the uterus. So all these patients, like we treated the average treatment time, like 1 hour and 40 minutes. Here is about the solidification time is around 20 minutes. So you can say from this table, you can say, I was so lucky because the first case was so easy. But actually, for adenomyosis, it's varying. Yes, every case is different. So that means we have to treat this patient individually and make the plan, and individual plan. So this is about symptom improvement. Among the 224 patients, 203 patients had dysmenorrhea. And after HIFU treatment, from this table, we can see we have around 30% of the patients had the symptoms, have the pain completely relieved. And some patients like had obvious relief, and also some patients partial relief. And also, like here is the clinic effective rate is more than 80%, but you will say we still have more than 10% of the patients didn't have the pain relief. Why? So I can explain later. So also for the patients have the, like among these patients, 109 patients had a menorrhagia. After we have around 80% of these patients had this symptom improved. So why? So here is the MRI classification of adenomyosis. It was made by Japanese doctors. Like from his paper, you can see he classified the adenomyosis as 4 types. This is the type 1, like intrinsic. You can see the adenomyotic lesion just located in the junctional zone and also involved the endometrium. But the subsoil and also the myometrium, there was low in the lesion, adenomyotic lesion. So they named this as a intrinsic, like the type 1. this is a type 2. I think we'll know exactly what it is. Like here, endometrium, and here, junctional zone, and here, part of the myometrium was normal, but this is the lesion, adenomyotic lesion. So also, you can see the rectum, also some lesions over there. So this is type 2, intrinsic, like the type 2. And also the type 3, like the intramural, just like intramural fibroids, they're like the same thing. So low involvement in the endometrium and also subsora. So for these 3 types, actually type 1, we can completely ablate the lesion and to achieve the symptom completely improved. And for this type, because we worry about the damage to the rectum, so at this time we just ablate this area, no damage to this area, but for the symptom improvement, so probably only partial symptom relief. But for this type, like the young lady, we can achieve, the completely symptom relief can be achieved. For the young lady, after treat this one, maybe they can get pregnant, something like that. I have some cases. For type 4, maybe like this, sometimes when you treat this kind of case, the symptoms are not going to be improved. So for different type, we have to give different treatment strategy. For example, like this one, we can completely ablate the lesion without any other things. We don't have to give the, we don't need to give the GnRH, then symptoms can be completely improved, relieved. And for this one, we have to combine with the hormone treatment. And for this one, I think it's okay. We can, even just a local treatment, we can achieve the complete ablation for the adenomyotic lesion. But for this diffuse adenomyosis, just like this, it's still intrinsic, but the whole uterus, they have the, adenomyotic lesion. So we have to completely ablate all of them to achieve the symptom relief. But for this type, it's difficult to achieve the symptom relief, even like this one. Probably for this one, we suggest just to go to hysterectomy. If they don't want to, then we treat with HIFU to make the uterine size getting smaller and also give some medication for the treatment. So this is some case we treated. Like this one, this patient was 39 years old. He had the symptoms, dysmenorrhea and menorrhagia. So she didn't want to have the hysterectomy, but after MRI, we found the lesion located the posterior wall of the uterus. But she was lucky because we didn't find like the DIE. So for this one, we decided to ablate all this lesion. This before the T2, this contrast enhanced MRI. So you can see the perfusion in the lesion. So this one day after the treatment, the lesion was completely ablated. Even this part close to the endometrium, we ablated this one. So you can see this 4 months after that, the treated area was shrank, was almost disappeared there, and symptom improved. But the most important, you can see here, the thickness of the posterior wall of the uterus was getting thicker. And you may ask, here is the lesion or the normal, like the uterine smooth muscle. But from the T2, from here, we can see clearly the single intensity, just like the anterior wall of the uterus, just like normal. It's a normal uterine smooth muscle. So only this small part of the lesion. So for this kind of patients, we can treat with HIFU and to achieve very good results. Here is another case. This patient was 48 years old. She had uterine fibroids before, and she had a myomectomy, but later found an adenomyosis, but she didn't want to go to the surgery. And then she came to us after an MRI because she already 48 years old. So I decided to treat this patient with HIFU. And I say if the symptoms improved, we don't need to give her any other medication. So after the treatment, one day after that, the MRI shows like this area was ablated, was perfect. So here is 9 months, here is 20 months. So the treated region almost disappeared, no recurrence of this patient. So like this one, I just want to show you how about the pregnancy outcomes of HIFU for adenomyosis. We have some cases like this young lady, just 26 years old. She married for 3 years at that time without pregnancy for 3 years, didn't get pregnant. Then because of the adenomyosis, when they tried different way, but didn't work. When they had the machine, the hospital, they invited me to go there and treat this case. MRI shows just like the type 3 adenomyosis in this area. So we just ablate this area. Then it was very lucky. So 2 months later, she got pregnant, but she got an induced abortion because she saw something. She took some antibiotics. So, but it was very lucky. 4 months later, she conceived again and delivered a baby at terms. So about the adenomyosis, now I can summarize. This technique can be used. It's promising in the treat. HIFU is promising in the management of adenomyosis. But for others, we tried. For example, like this case is a bladder endometriosis. I treated this patient with Felix Wang from Hong Kong. We treated this patient together. Actually, it's his patient. He invited me to go there to treat this case with him together. And you can see 35 years old, presented with recurrent hematuria and dysuria every month. And she was 35 years old and she wished to have a baby. So if we perform like the bladder resection, then a large part of this, a large bladder resection will cause the uncontrolled ruling and thinning of the uterine wall. So it's going to take a bigger risk. So after discussing with the patient, then we try to first give the HIFU treatment for this area, then give GnRH to control the symptoms and try to let her get pregnant and complete childbearing. Maybe later we perform the surgery later. The patient agreed. Then we treat this patient last year, October 31st, 2019. So now already 1 year. So here is before HIFU treatment. The contrast enhanced ultrasound show the lesion here. And this is real-time ultrasound image. We are treating this area, also the adenomyosis here. And this part of the bladder endometriosis. Here is after HIFU treatment, the contrast ultrasound shows no perfusion in this area. Compare this one with this part. So it worked. So after HIFU treatment, no any complication occurred. So no fever, no hematuria, no dysuria. So after HIFU treatment, this patient was given 3 cycles of GnRH. So now already 1 year, she didn't have these symptoms come back. So we also use HIFU to treat the patients for abdominal wall endometriosis. So probably this is more often seen in China, but maybe not in Africa, because we had a very high cesarean section rate over the last 10 years. So now we have a lot of patients like the abdominal wall endometriosis. So traditionally, when we treat this one, we have to perform the surgical resection under the abdomen. And so for HIFU, we just treat this under conscious sedation. We can, because the lesion was very superficial, the HIFU treatment, the response to HIFU is very sensitive. For example, like here, you can see the grayscale changes like this. So we can treat this one under conscious sedation, and after treatment, they can go home like 2 hours after the treatment. So it's very good for HIFU to use to treat the abdominal wall endometriosis. So about the others, I think we should try in the future. Recently, like some doctors from other countries already discussed with me about if we can use HIFU to treat like the posterior compartment of DIE. So like this case, like here, like this one. So we know that if we perform the surgery, it's very large, it's very difficult. So can we do something different? So we will think if we can make some device, for example, the transrectal degassing water sac to insert from here to move the lesion away from the other side of the bowel. Then we can up this area. After the treatment, we can combine with the hormone treatment. Maybe we can help this kind of patient, because for this kind of patients, like the surgery, the complications are very large and very high. So maybe we should try something like this. And also maybe in the future, we can do something with you guys together. So this is my city. It's Chongqing, like the southwest of China. And this light view, you can see this is Jiangling River. Also, another side is the Yangtze River. So it's I think it's very beautiful. So I hope someday in the future, you guys can visit my city. Thank you very much.
Thank you very much, Dr. Zhang. That was a wonderful presentation, and thank you very much for bringing this to light. I would like to call Professor Odukogbe to start with this question and then take us through a couple of the questions. I'm sure that Dr. Juwan Labi should be getting ready because I have quite a lot of the questions directed at you.
Thank you.
Thank you very much. Like the president said, Dr. Femi will take the first question. So Femi. Hello.
Yes.
Please. Femi will take the first question.
Femi has left.
Oh, okay. Oh, okay.
You can throw it open. I'm sure somebody.
Dr. Larik also had a question. I think he wants to answer it. Dr. Larik.
Dr. Larik has gone to attend to a patient too. So, but.
Oh, okay. I thought I saw.
Okay. But it's still on, but it's because he promised to come back, but he's not back.
I think it's back.
Okay. Oh, okay.
Dr. Larik. Okay. President, my phone timed out, so I don't have the question.
Okay, let me give some of them. Well, one of the first questions, and a lot of these questions had been answered in the presentations. It's just that they kept coming, perhaps people timed out and all that. Somebody asked a question. One, what effect does laparotomy have on endometriotic, additions following, from endometriotic surgery compared to laparoscopic? That's one. Somebody asked, how do you handle thoracic endometriosis? What is your experience on biopsy from the chest to confirm the diagnosis? Then somebody asked a question, is it possible for someone with endometriosis to conceive without IVF? That's from one of our members of the society and all that. And I think it's important that we look at this. Somebody asked a question, considering the paucity of skills and facility for laparoscopic surgery, is there a place for open surgery in the management of large endometrioma? I also have questions. One of the members, perhaps of the endometriosis support group in Nigeria, asked this question. I was diagnosed of endometrioma and I had surgery in April this year, but it is growing on the right tube. Is there a medication or precautions such as lifestyle modifications that I should take? A certain person, TF, asked the question that 19 months after having myomectomy, I developed pleural effusion and I've had pleurodesis done severally. Infertility is also a concern here. Is it the myomectomy that triggered the recurrent pleural effusion? I think we'll just help because it's one of the people who asked that question. Then this question, I think, is deliberately to Dr. Juan Alabi. Said, complications in babies born to mothers with endometriosis, do they also require surgery? Do the children require surgery? Another one is, how does endometriosis cause damage to the endometrium? I think we had a lot of answers to that. But again, the question has been asked. So I'm sure that we will be grateful if you just oblige by answering them. Then could the higher incidence of multiple pregnancies in these patients be due to the use of ovulation-inducing drugs? Then it says, then what are the fetal outcomes in endometriosis? I know Dr. Alabi talked a lot about fetal outcomes then, but the question is being asked again. One of my very, very good friends and senior colleagues in Lagos, Dr. M.O., asked this question. He says that since all obstetric complications, as you can imagine, seem to be worse with endometriosis, perhaps we need more studies to reduce the anxiety and fear that Dr. Juwon Alabi has kindled in all of us. It kindled in all of us. And then OF, somebody asked the question, and I think that question is also very pertinent. He wants linkage for training. I guess this will be, you know, Dr. Chairman of our subcommittee, Dr. Abayomi Ajayi, also has a foundation that is actually into mentoring young physicians. And it's important that they're thinking of training opportunities and all that. So we're asking about how to link all the faculty so that, and I know that Dr. Juwon Alabi offered that, Dr. Musivagong, that's Olaric, also invited people to come to Thailand for training. And so this person is asking for linkages, and I'm sure that the chairman of the professional development would be the person to approach, perhaps not just on this podium for linkages, all these training linkages, because he's deeply, deeply, deeply also committed to professional development. Thank you very much. So those are the questions that I have listed, and I'm sure that we've taken them down. If you can answer this, we will have done justice to this wonderful lecture. Thank you very much. So, Dr. Ajayi, do you have any questions amongst these to answer?
Is it possible to conceive without IVF with endometriosis? We answered that. We said it's only about 30 to 50% of patients who even have infertility. So the other people conceive even without anything. So it's possible to conceive. Somebody said 19 months after myomectomy, another one is she's been having recurrent pleural effusion. That's likely that's not even fibroid. Maybe that was endometriosis, that was adenomyosis. So I think she should talk to the doctor again. That's probably endometriosis, you know, so they can have a look at that. And what can cause damage to the endometrium? Yeah, like you said, we spoke about association with adenomyosis. We thought initially that we still think that there is a progesterone resistance. Of course, we know that endometriosis is an inflammatory disease, so everywhere is inflamed, including the endometrium, you know, but there was a study recently that showed that the window of implantation actually with endometriosis is not different from other people. So using RNA, the ERA test, they showed that that was not. So mainly adenomyosis is known, that's proven. Okay, we think also there might be progesterone resistance in cases of endometriosis. Could the higher incidence of multiple pregnancy be due to use of stimulation drugs? Well, I'm not aware of incidence of multiple pregnancy being higher in patients with endometriosis, except of course, if they use IVF, then that might make it to be, the incidence might be higher. So I think those are my own questions. I don't know. If I missed out on any, please remind me.
Thank you. Dr. Alabi.
Okay, so I think I have a question. Somebody asked whether how does endometriosis patients have placenta previa? And in my lecture, I did mention, I mean, nobody can be 100% about the causal association, but there, you know, it's all theory. So the first one is that there's altered uterine contraction, which affects the blastocyst implantation. If the womb is moving and contracting, and so they believe that instead of the blastocyst attaching at the upper part of cavity, it attaches at the lower part. The abnormal placentation is because of possible associated trauma or adenomyosis. I think somebody asked that, are there studies? Now, one of the things about medicine now is that so the articles I presented are meta-analysis, so they're good evidence. And if you look at one of them, there's 3 studies in it. So I think one of the things we are looking at is that once they get pregnant, we feel that we have done what we need to do. So I guess that from this lecture, we need to start looking at the obstetrics and probably start classifying them as high risk, rather than say, oh, now that you've gotten pregnant, there's no more problem. I think that's about, I can't remember any other, I think Dr. Ajayi has answered some of the, I can't remember any other question that is from the outcome.
Okay.
Thank you very much. Femi is back now. He might take that question that Professor Dukube asked then.
Thank you so much. I'm happy to do that. So, I think I alluded in my talk that the most people would, in this instance with endometriosis, would go with oocyte freezing and embryo freezing, like you said. However, when you were talking about getting the cortex, usually this is in normal ovaries. So in patients who have other kinds of cancer, and we're talking normal ovaries. So it's actually not too difficult laparoscopically to take sleeves off the ovary, the normal healthy ovaries. And it's a pretty simple procedure to actually go ahead and take slices of the cortical part of the ovary and send that, because you have the embryologist there in theater, and get that frozen at the same time and get it sorted out. So it isn't a difficult thing. Yes, there is no, I mean, they have a look, the embryologists have a look in theater, and while you're there, and they make sure that they are actually normal ovarian tissue, and they just freeze it. So it's not a difficult procedure at all, and it's pretty straightforward.
Thank you.
Thank you. Actually, we have about 7 hands that are raised. Unfortunately, I had said maybe if you have questions and answers, they are better put on the platform so that we can read them, because we might not be able to actually activate the audio such that audio access, except of course the technical people say it is possible. I have 7 people raised hands, but there are a few other questions. And this is from a potential member of the African Endometriosis Awareness and Support Group. So I'm sure we must take the question. What are the chances of conception in a 31-year-old with regular painful menstruation with ultrasound diagnosis of left ovarian endometrioma? She is hoping to conceive soon. Will it be wise to allow her push through with her plans while observing her? That's the question. I think it's on endometrioma. I'm sure that if Olarik is around, he would have been in a better position to answer. But if that's not, anybody can answer that question for us. Please take another question. This is from an anonymous person. What are your thoughts on progesterone primed ovarian stimulation for IVF in patients with endometriosis? And the second question, in a pregnant patient with IVF with endometriosis, what advice or precautions can be taken at delivery? That's, I think, to Dr. Alabi, since it's again managing complications that arise in endometriotic pregnant women. So those are the questions. Anybody wants to have a go at particularly that question from on the endometrioma?
Professor, how big is the endometrioma, sir?
Well, as you can see, unfortunately, it's not stated, just a very big endometrioma. Left ovarian endometrioma.
Yeah, can I say something?
Yes, sir.
You know, we said something that we are not treating lesions. If this patient does not have infertility, which she does not have, she does not have pain, I think it's probably we should just be following up that kind of patient. Okay. From the look of it, she's not even trying to conceive yet. You know? So if anything, I think it's Femi that probably will be useful to her. But it's only one side, not even bilateral. So I think just let sleeping dogs lie. That's my own opinion.
That's a brilliant answer, because actually that's what I say, that do you want to see and observe? That's the question that the person has asked. So progesterone prime stimulation, ovarian stimulation. I can see not many people are asking about IFU because it's a little bit above our heads. Not many people are asking
we have
me that question.
We have a question on IFU.
Okay, I have not seen that.
Do you use bowel prep prior to IFU?
Oh yeah, what are the common complications associated with IFU? And do you use bowel preps? Yes. Okay. And somebody asked a question. I dare say that maybe Dr. Ajayi will be able to answer that. So what is the cost of IFU machine?
So I don't know. I'm not a businessman, so I don't know the price. Probably different places have different price. I think there's a price. But you know,
Professor Zhang, I'm not even asking you for the price. Please just ask, do you need bowel prep? I leave Dr. Ajayi to answer that question about the pricing.
Yeah, I'm just kidding. For the complication of IFU, actually, I mean, this technique is non-invasive. So the complication rate is 10 times lower than the surgery. So in my country, in my department, for like the common side complication like the skin burn. If the patient had the surgical scar on the abdominal wall, so when we treat with HIFU, probably this patient has a higher risk to get a skin burn. So then if they like during treatment, you have to often check the skin, and also from the ultrasound you can see, and also you can check with your hand then to prevent the complication, prevent the skin burn. Another one is about like the nerve injury. Sometimes you have the celiac trunk close to the lesion. So if you don't have the experience and the patient tell you she had the leg pain, then you have to move the transducer away from there. Otherwise, will cause a skin and nerve injury and leg pain after the treatment. So the main complication of HIFU, just like these two, skin burn and leg pain after the treatment, but the rate is like 0.2%, so very low.
Thank you very much.
Thank you.
Dr. Ajayi, did you want to answer the other question?
What's that?
How about the cost? The cost.
The cost.
Yes, cost of the machine.
Maybe you reserve that for the last, because I don't want to scatter this gathering yet. Definitely, I'll mention. I have an idea.
Okay, and several people also have asked about the presentation, how they can get the link to the presentation. I think just a word from Dr. Ajayi too.
Oh yeah, we'll see how we can do that. We'll see how we can do that.
There was a question somebody asked about if somebody comes to term with endometriosis, how do you deliver? I think so everybody have different risks they carry through pregnancy. If despite the endometriosis, they happen to have a cephalic presentation at term with no major problem on the womb, they will be offered a vaginal delivery. But obviously, I think they're not different to anybody's delivery. But obviously, I think individualized care matters. It's very good. Oh, you're going to manage everybody the same way. It depends on what they bring on the table.
Thank you. Thank you very much. I haven't seen many more questions. I think a lot of these questions have been answered. Somebody said, I remember the second, considering the paucity of skills and facility for laparoscopic surgery in Nigeria, is there a place for open surgery in the management of large endometriomas? Remember that? Somebody please answer that.
I don't know whether Dr.
I think I leave it between you and Dr. Larogu.
So, I mean, what I've got to say is, I mean, we hardly ever have to do an open procedure on a patient with no matter how large the endometriomas are. The reality is that you see a lot better and you're able to do probably much more with laparoscopy. But I mean, my advice would probably be to the Nigerian setup to perhaps refer these patients to units where there is the expertise. I know it's not like in every city or every town, but it's still the best way to treat those patients is refer them to units where the expertise might be available. I know cost might be a factor as well, and I understand all that. I suppose in the absence of all that, if they can't afford it and all that, you can obviously do open procedure, but serious consideration has to be given to trying to get it done laparoscopically first. That would be my take on it.
Yeah, so I think my take would be that as a member of the Association of Gynaecology of Nigeria, a lot of people, so if you look at the geopolitical area in Nigeria, might be one or two people doing stuff in different areas. We need to start encouraging for people, referring people to units where it can be done. I mean, there are some people in the northern teaching hospitals that do laparoscopy. I don't know what extent they do. There are some people in the southeast that do. They do a lot of laparoscopy in Dr. Ajayi's clinic in Nordica. We do a lot of laparoscopy as well. So there are a few. I mean, one of the major problems I see sometimes is when people have had open surgery for endometriosis, and when you go in, it's almost as if, oh, why was this? Everything is stuck together, and it makes the surgery a bit more difficult. So I do understand that sometimes you might not have the privilege of a laparoscopist, but you have to start thinking about. I like what the gentleman in Thailand put on. You have to not only think as doctors, you have to think like a man. So always think about the best interest for that patient, always. I think that's important.
And important also to note that what we as a society, that's a society of SOGON, what we've been doing actually is to perpetuate, that sub-specialization and encourage people so that we can increase the skills and the facilities where they are deficient. And I think the rate at which we've been going, we'll be able to get there soon. So that's probably one of the best ways to solve that problem, is to make facilities and skills more readily available. And on the lighter side, one of the persons who posted the question earlier, who told me about attachments, which I read the other time, has also specifically clarified that point, that he's not talking about local attachments. He's talking about attachments outside of Nigeria. So I just thought that I should also let Dr. Ajayi know that, so that when he's helping, he's going to be facilitating that better. So, Pastor.
Oh, yes, sir.
Please, do you still have questions? Do you have any questions and all that?
No, they've been answered. Only that the last question concerning laparotomy, that would still be a cohort of patients that must have open laparotomy. Not everyone can have laparoscopic surgery. There will still be some that you will need laparotomy, and especially when organs are matched together, and for some of them even requiring colectomy, hemicolectomy and things like that. Open laparotomy will be necessary. And I also, well, just chip in, training within the country will still, to my mind, will be a lot cheaper, and the personnel will be able to practice on what is available and what they will come back to. Because oftentimes you see people, if you are going abroad and you are practicing there, fine. But if you go to train in places where you meet a different set of pathology, you might come back and not be able to function, which has happened a lot of times in these cases. So local training, if I may put it like that, local training is important. And these days, there's a lot of collaboration. I mean, for this talk, we've had people from 4 or 5 overseas countries collaborating with us. Surgeries now can also, by telemedicine, you can do a lot of training through that. So really, there's a lot that can be done in-house. Thank you.
Mr. President.
Sir.
Yeah, I think the first time I joined the AGL was 2004. And then only about 4% of the gynecologists in America, they did a study that were doing gynecological endoscopic surgery. And you have seen what has happened now in the spate of how many years? 2004 to now, about 16 years. The picture has changed dramatically. And so I think there is hope also for Nigeria. We just need to be patient. It has started, it's just going to snowball. And then and that's why for me, I think we need to continue to encourage the younger ones. When it comes to eye-hand coordination, younger people are better than those of us who are gray-haired. There is no two ways about it. They need to start at an early age, okay, and then grow into it. So I think we should try to support the younger ones in our units to get used to this. I was in a place in Germany. The problem they had was that they said they had not done open surgery in about 10 years. Everything is done laparoscopically. So I think that's a good problem to have in Nigeria. So I think it's not too late for us. I think we're on the right path, and I'm sure we should be able to get there.
Thank you very much. I am aware that most people actually are talking about low dose, high frequency training, which is on site. So that basically speaking, it's a lot cheaper. You get better results and all that sort of thing. So we are working on all sorts of options. And at this stage, I think I can only say, I don't know what Dr. Odukobe will say, but you find out that all the chat box has been very, very full. It's been full of appreciation to everybody for the faculty, or the wonderful faculty, for the precision, for how penetrating the lectures have been. So people have been very, very grateful to faculty for bringing these lectures together. And there's nothing else I believe that we can do other than to join all the participants. You will understand the fact that at a particular period, we had about 540 people on the podium, in the platform, following this discussion. And we still have lots of people on YouTube accessing this on YouTube. So if you have about 540 people, as we talk, we are still over 300 people on the platform. And we are like into the 4th hour of this lecture. So it shows how interesting it has been, how much, and it's interesting because I remember when we were in Rio de Janeiro, we found SOGON members in the diaspora there. You also have the Femis who are in Cape Town, everywhere, and you find out that I'm sure even if you have to go to Guangzhou, anywhere, you'll find Nigerians there who are also, and they will be, they are welcome and they are available, so that we use faculty both at home and abroad to actually strengthen our society. Have the Dr. Ajayis, the Dr. Alabis, all contributing locally, and then we're bringing in all that much expertise. So I must thank, seriously, Dr. Olarik Musigabano and Professor Lianzan for what they have done. And more importantly, I know that he has left. That's Professor. I know that I can hear Swahili in the background there. So I know Professor Kamona has left. He brought a very fantastic when he gave us Manuel Amunike when he was in Barcelona. And so we've been able to talk about, and then you can see that Olarik brought in both Lionel Messi, he brought in my friend there, Ronaldo. So you find out, for example, that all these things are interlaced, and they're so, makes it so very, very, very rich. I'll be looking forward to the day when we start having IFU centers in Nigeria. I am aware that currently there's probably only one IFU center in Africa, and it's in South Africa. So I must thank you very much, Professor Zhang. I must thank you, Femi. for being so good to give us this lecture. I want to also thank Olarik for the wonderful presentation he gave us there, and Professor Kamona. And more importantly, I want to thank my co-moderator, Professor Dukogbe. He's my pastor, so you can understand how I feel every time I see his white mane, and I have to bow and show my respect. Of course, Dr. Ajayi has been doing his job, and he's been doing it so wonderfully well. He's the chairman of SOGON's continuing professional development committee, and he has performed, and I can't say beyond expectation, because we expect so much more. I thank you all for your attention, and I wish you save money back to wherever you are, whether it's South Africa, or whether in China, or whether it's in Brazil, Barcelona, or whether even it is there in our wonderful Thailand. We will be visiting you soon. Thank you very much.
Thank you.
Yes, thank you. Thank you. I just want to thank the people who made this possible. The HIFU and Abby, we shouldn't forget them from Germany. They sponsored last week. And yes, the cost of HIFU machine, you still want it? Let's keep it coming. Thank you very much. See you some other time. Thank you.